with thrombocytopenia, as early diagnosis and timely intervention would prevent adverse outcome and saves life. Aim and objective of this study is to study the clinical presentation of and profile of febrile illnesses causing thrombocytopenia under etiological basis, and to study the complication and prognosis of febrile illnesses with thrombocytopenia. This is a cross-section observational study conducted in Jagjivan Railway Hospital after getting approval from Scientific and Ethical Committee for a duration of 1 year in year 2021 to 22. Sample size was 150, and both patients from both the genders are selected from 1 month to 18 years of age after taking written consent from their parents, and only patients who are getting a thrombocytopenia on CBC we have included them. So inclusion criteria are both sexes, age 1 month to 18 years after taking written consent from parents, and patient attending OPD and IPD with thrombocytopenia. We have excluded patient presenting with thrombocytopenia without fever, diagnosed cases of thrombocytopenic purpura on treatment, patient with thrombocytopenia already diagnosed to have hematological disorder like malignancy, and those who are on treatment with chemotherapy or other immunosuppression. Patient on treatment with antiplatelet drug and other drug that causes thrombocytopenia, we have excluded them. Observation and result from my study are, as we can see, maximum number of cases was found in the age group of 5 to 10 years. With the male predominance, male 56% and female 44%. Maximum number of cases were reported from month of June to August, followed by March to May, and least in the month from December to February. Common range of platelet count that we encountered at the time of admission was more than 50,000. Associated clinical features reported from the maximum number of patients was headache, followed by body ache, abdominal pain, followed by nausea, vomiting, icterus, hepatomegaly, and the least with altered sensorium. Most who showed bleeding manifestation were found to be dengue cases, followed by malaria. Among the cases with bleeding manifestation, petechia and purpura was the commonest presentation, and infection is the most common etiological cause. The acute undifferentiated febrile illnesses were commonest cause, where we couldn't find the definitive diagnosis. Dengue formed the second largest in the group, and followed by malaria, the third largest, with Plasmodium vivax the commonest. The majority of patients have developed hypotension as the most common complication in the study. Among the mortalities, severe dengue was the commonest etiology, followed by septicemia. And among the mortality, and the death in the outcome was mostly due to multi-organ failure. So these are my conclusion. Maximum number of cases I have discussed, as it is in 5 to 10 years with 56% male to 44% female. Infection is the commonest cause of fever with thrombocytopenia. Acute undifferentiated febrile illnesses were the commonest cause when a definitive diagnosis couldn't be made. And dengue formed the second largest group in the diagnosed case. Malaria was the third largest, with Plasmodium vivax being the commonest. The common range of platelet count encountered at the time of admission was 50,000. Only one patient presented with platelet count 10,000. Most who showed bleeding manifestation were found to be dengue cases. Hypotension was the most common complication found in the study. Among complications, severe dengue was the most common etiology, followed by septicemia. Death in the study were due to multi-organ dysfunction. These are my references. Thank you.
Yes, sir. Okay, thank. Thank you, Atiola, and he has been awarded the third prize for our free paper presentation. Now I am going to invite Dr. Dhanasri, and she is going to speak what she had done as a free paper presentation to get the second award. So Dr. Dhanasri, you are welcome to the podium.
Good morning, respected delegates, consultant, teachers, and my co-JRs. I'm Dr. Dhanasri Mestri, junior resident from Department of Medicine. Today, I'm presenting a case series on latent autoimmune diabetes in adult. Immunology of Diabetes Society defines latent autoimmune diabetes in adult as adult age of onset of diabetes for more than 30 years of age, insulin independence for at least 6 months from the time of diagnosis, plus positivity for diabetes-associated autoantibodies. It has been observed that LADA accounts for around 2 to 12% of the total diabetic population and 20% of the patients who were initially been diagnosed with type 2 diabetes. The reported features were onset of diabetes at age of more than 25 years, clinical presentation masquerading that of type 2 diabetes, non-significant family history, evolution to insulin necessity within months, and some features which are similar to type 1 diabetes include non-obese individual, low fasting C-peptide level, and positive GAD autoantibody. India at present is witnessing an epidemic of type 2 diabetes, and it has been observed that onset of this type 2 diabetes occurs at an early age in Asian population. Hence, in India, where diabetes affects a significant sector of the society, the study of prevalence, characteristic, and immunological markers of LADA would help to provide a valuable insight into the underlying similarities and differences in other types of diabetes. So my aim here is to create awareness of LADA for appropriate and early diagnosis so that appropriate treatment can be initiated in them. This case series includes 7 patients who presented to the OPD or IPD with complaints ranging from poor glycemic control to acute hyperglycemic episodes such as DK, who on evaluation were found to have latent autoimmune diabetes in adults. The inclusion criteria were adult age of onset of more than 25 years of age, insulin independence for at least 6 months from the time of diagnosis, and positivity for diabetes-associated antibodies. The exclusion criteria is type 1 diabetes and gestational diabetes. Various parameters such as the age, sex, age of onset of disease, the duration of diabetes, family history, BMI, lipid profile, HbA1c level, FBS, PPBS, C-peptide, GAD autoantibody, thyroid profile, the medications which the patient was on, such as the lipid-lowering agents, the oral hypoglycemic agents, and antihypertensives were all recorded. Blood samples were taken between 8 a.m. and 10 a.m. after a minimum of 8 to 10 hours of fasting. HbA1c was an indicator of the glycemic control, and it was defined as a poor glycemic control for more than or equal to 7%. C-peptide was used as an indicator for beta cell capacity. A reference range of 1.1 to 4.4 nanogram per ml was considered. Anti-GAD antibodies were used as these are the most commonly associated antibodies with LADA, and a positivity of more than or equal to 10 international unit per ml was taken. So it was found that out of the 7 patients, 4 patients were male and 3 were female, indicating a male preponderance. And the average age of onset of disease was around 36 years. Out of the total patients, 3 patients had history of family history. There are no studies, family history of type 2 diabetes. There are no studies as such of an exclusive genetic pool for LADA, but it has been observed that LADA is associated with type 1 diabetes with association with HLA-DR3B1. And the type 2 diabetes association is with transcription like factor 7 gene. The average HbA1c observed was 10.9. The average HbA1c observed was 10.9, indicating a poor glycemic control. Though these patients were on multiple OHs for the treatment, such as metformin, sulfonylureas, DPP-4 inhibitors, and thiazolidinedions. 5 patients presented in DK, 1 patient presented in candidal melanophysitis, and 1 patient presented with uncontrolled diabetes. All patients were having normal BMI, normal HDL, LDL, triglyceride level, which was in accordance to the reported data. So in conclusion, there is a need for a screening tool for early identification of such patient so that a personalized therapeutic approach is set in order to slow down the autoimmune process and preserve this beta cell function. Forlanas et al., he developed a LADA clinical risk score, which includes 5 clinical parameters: age of onset of less than 50 years, acute symptoms of hyperglycemia before diagnosis, BMI of less than 25, personal and family history of autoimmune disease. Such clinical risk scores with C-peptide level could help us in an initial diagnosis, and it can be a cost-effective method for the diagnosis. Later, they can be confirmed using a GAD autoantibody test. Our aim of treatment should be an adequate glycemic control to prevent the beta cell impairment and to prevent the diabetic complication. Considering the autoimmune response in LADA leading to beta cell impairment, insulin therapy should be the ideal treatment of choice in these patients. But these patients, they can also be combined with DPP-4 inhibitors and GLP-1 receptor agonists as an add-on therapy to sustain the residual beta cell function, especially in patients who are having a relative maintenance of the C-peptide secretion. So my take-home message to all is careful evaluation of these patients to prevent misdiagnosis as type 2 diabetes. When to have a high suspicion is when a young non-obese individual presents to us with uncontrolled diabetes or with diabetic complication. Early initiation of insulin would help to prevent beta cell exhaustion, glycemic control, and also to prevent the complications of diabetes. Thank you.
Hello.
Thank you, Dhanasri, for your excellency. Now we are going to have Dr. Prashant on stage, and he has been awarded the first presenter, that is his first award for the case paper presentation. And now I invite Dr. Prashant to be here only. Dr. Prashant Salve.
Hello.
Good morning, everyone. I am Dr. Prashant Salve. I am third year cardiology resident in Jagjivan Railway Hospital. Under the guidance of Dr. Shishi sir and Dr. Avinash sir, I am going to present paper today. Paper on study of clinical profile and short-term and long-term outcomes of patients undergoing left main coronary artery interventions. As we all know that left main coronary artery is supplies 75% of the left ventricle in right dominant patient and 100% of left ventricle in left dominant patient. LMCA disease is a critical disease which leads to reduction of blood flow to the large portion of myocardium, and that leads to LV systolic and diastolic dysfunction and arrhythmias. As we all know, the left main is divided into 3 parts, that is proximal, ostium, then mid segment and distal part. The distal parts gives rise to 2 main epicardial branches, that is left anterior descending and left circumflex. Around 4 to 9% of the patients undergoing coronary angiography are found to have left main stenosis. The treatment of unprotected left main coronary artery lesion by coronary intervention or CABG remains the major challenge nowadays. So as we all know that main treatment for left main stenosis is CABG or left main stenting. For the deciding of the modality of treatment, there are various scores, but most commonly used score is syntax score. If the syntax score is less than 22, there is a PCI is a modality of choice. If the syntax score is 23 to 32, angioplasty or CABG has equal outcomes. If the syntax score is more than 33, CABG is the modality of choice. However, in some patients, due to the severe comorbidities, the patients were not fit for CABG, or the patients were not willing for CABG. For those patients, left main angioplasty is a main alternative and best choice available. So aim of my study was to study the clinical profile, short-term and long-term outcomes of patients undergoing left main angioplasty for left main disease and its branches, to correlate the clinical outcomes of coronary angioplasty with respect to risk factors like diabetes, hypertension, dyslipidemia, and to observe the clinical endpoints like unstable angina, reinfarction, rehospitalization, and death during follow-up. So my study was hospital-based single-arm trial, which was uncontrolled interventional study, which was conducted over 24 months from March 2022 to Feb 2024 in the Department of Cardiology, where 30 patients who underwent left main angioplasty were enrolled. So the patients who had myocardial infarction and who underwent left main angioplasty, and willing to give consent were included in the study. The patients who are not willing for intervention or underwent previous CABG or who had valvular heart disease or not willing for giving consent are excluded from the study. All the cases who underwent left main angioplasty and given consent included in the study, where their clinical examination, details of blood investigation, ECG, echo, and details of coronary intervention has been recorded. These were followed up for 1, 6, and 12 months. During their follow-up, their details clinical history and blood investigation was done, and coronary angiography was done in all the patients over the follow-up period of 1 year or as soon as patient develop any symptoms. The endpoints being mortality, all-cause mortality, reinfarction, unstable angina, recurrent hospitalization. Coming forward to results, 63% of the patients were of my study were males. The 50% of the patient belongs to age group of 61 to 70 years, that is, and average age being 66 years. The hypertension, diabetes, dyslipidemia, and smoking are the major risk factor to having left main stenosis. The 40% of the patient belongs to moderate LV systolic dysfunction, that is 35, LVEF 35 to 45%. Various techniques has been used in LM stenting. The most commonly being used is provisional bifurcation technique, followed by Delegates crush and tap technique. In most of the patients, we use 1 to 2 stents, but in few cases, complex cases, we have placed even more than 5 stents in multiple settings. So here I am going to show some angiogram of some of my patients. So this patient has left main disease and LAD and L6 disease. So it was tackled with left main to LAD and L6 stenting done by Delegates crush technique with good result. This is another patient where the patient has a left main and LAD disease. So it was tackled with left main to LAD stenting. It was done and with the good result with provisional bifurcation technique. So coming to the outcomes during follow-up, though 37% of the patient had cardiac symptoms in follow-up, the 17% of the patient has left main stent restenosis during follow-up, and the 7% of the patient were succumbed to death during follow-up. So we have found in our study that the patients with diabetes, hypertension, dyslipidemia had more risk for developing cardiac symptoms during follow-up, and while the patients with hypertension and smoking has more risk to develop restenosis of left main stent. So the techniques were used, various techniques were used for left main stenting. Out of that, the decay clot and tap technique is have more prone for developing left main stent restenosis. So coming forward to discussion, the patients who underwent left main angioplasty had many risk factors as ASCVD. The clinical presentation of patients with left main disease is more alarming, which needs to aggressive management. The left main angioplasty under guidance of imaging was done successfully in all the patients without any immediate complication. The patient who underwent left main stenting with decay crush technique, the double kissing crush technique, has advantage over other techniques. The patients who have more risk factors are vulnerable for left main stenosis, making them more prone for reinfarction, heart failure, arrhythmia, stroke, and which may lead to death. Those patients who are compliant to drug had good clinical outcomes with patent stent. Finally concluding, the left main angioplasty is one of the novel technique to deal with disease with left main, which is alternative choice of CABG. Previously, only the CABG was the mainstay of treatment for left main disease. Nowadays, due to the imaging modality, we are able to do angioplasties also. So patient selection is very important, and imaging is very important for those. Imaging is very important for the proper stent selection, placement, and better clinical outcome. Patient with multiple risk factors having worse short-term and long-term outcomes. So far as long-term outcomes are concerned, it depends on patient clinical profile, type of coronary intervention which is used, techniques which are used, the number of stents which are used, and the drug compliance. The large volume of data is needed to compare short-term and long-term outcomes, safety, efficacy, and left main of left main angioplasty in comparison to CABG. Thank you.
Thank you, Dr. Prasad. All will be awarded at the valedictory function only by our respected DG RHS ma'am. And along with her paper presentation, we had highest number of entry for the poster presentation, and which well carried out by Dr. Pradeep Rana Vijul sir and his team. Excellency 23 out of 23, three poster was awarded best, and we will announce in between. And now I open the session for the first session, and I invite Dr. Trupti to take over the mic. Thank you, Dr. Trupti.
Morning, everyone. The chairperson for next session is Dr. Simi Gupta ma'am, CMS Ratlam, and Dr. Ashok Kumar sir, CMS Dahod. The speaker for the next session is Dr. S.B. Gupta sir. The topic is ECG, what it holds in future.
Dr. S.B. Gupta, I don't think so he requires any introduction, but as a protocol, ex-consultant, physician, cardiologist, Asian Heart Institute Research Center in Mumbai, past president, Cardiological Society of India, Mumbai, former head Department of Medicine and Cardiology, Central Railway Headquarter Hospital, Mumbai, past dean, Indian College of Physicians, past president, Association of Physicians of India, past president and current advisor, Indian Society of Electrical Cardiology, past president, Indian College of Cardiology, former international governor, American College of Physicians of USA, former chairman, Railway Chapter of Association of Physicians of India, governor, American College of Physicians, Indian Chapter, 2016. Sir, I would request you to start your presentations.
Good morning to all of you, and thank you very much, the chairpersons. Nice to be back on a railway platform again, because railways are in our blood. So the topic which has been allocated to me by Shishir is ECG, what it holds for future. And at the outset, I must thank Dr. Shishir for asking me to give and deliver this talk. I think we know about the ECG time immemorial, and it's more than a century that ECG is there. And still, I think a lot of changes have happened in different investigational approaches, but ECG still holds that after even completion of more than 100 years. It's the first investigation if you are suspecting any chest pain for the diagnosis of acute coronary syndrome, you'll advise ECG. If you are suspecting any arrhythmias, again you'll advise an ECG, because no other investigation can match the ECG as far as acute coronary syndrome is concerned or arrhythmias management is concerned. But I think there is a lot of things in the future of the ECG, so I'll just talk about that. In the ECG started its journey somewhere in 1842, and in 1893, the father of ECG, Einthoven, have invented the term EKG. And since then, I think a lot of developments have come, and in 1924, Einthoven was awarded the Nobel Prize for his discovery of ECG. And that's how I think these pictures everyone must have seen. In this was the type the ECG was recorded in early 19th century, and this was the type of the galvanometer on which the ECG was recorded. And this was the first ECG which was recorded by Einthoven, and you can see the ECG in 1920 and today's ECG, it almost looks the same. The PQRST complex. So as far as tracings are concerned, whether it was taken in early 19th century or now, the ECG remains, the tracing remains the same. And this was the Nobel Prize which was awarded to William Einthoven in 1924. I think nowadays there is a lot of computerization of the ECG. I think a lot of machines are there where ECG, the computer gives the diagnosis. but I always tell so far the ECG machines which are giving the interpretations, it's always better to filter those diagnoses by the computer, because a lot of time misdiagnoses are there. And if you give those interpretation directly to the patient, almost 80% of the ECG will use the word abnormal ECG. And once a patient sees that his ECG is abnormal, I think the panic starts. So one has to be very, very careful about giving these computer-aided reports for the, to the patients. I think a lot of advances have happened in the last 2 or 3 decades about the transmission of ECG. The patient records the ECG at his home or in a nearby area, and the same ECG can immediately be transmitted to his treating physician or cardiologist, and immediately within minutes the diagnosis can be achieved. So there's, I think, a lot of new things are happening as far as the transmission of ECGs are concerned, whether ECG is being transmitted by a smartphone, tablet, laptop, or through his desktop. It may go directly to the physician or cardiologist, or there may be a center where the ECG goes there, and from there the ECGs are being transmitted. So there have been a lot of advances as far as transmission of ECGs are concerned, and these are called as maybe, I'll not use a lot of things. These are the cloud ECG which can be done. And the other thing is about the recording of the ECG. There have been a lot of developments have occurred in last few years about the recording of the ECG. We have so many devices which have come, like Apple Watch is there, which I think a lot of people may be wearing in this hall also, where one can at least see the rhythm of the ECG. So if there is any irregularity of the heart rate, it can be recorded and again can be transmitted to his physician or cardiologist, and they can say whether this irregular rhythm is of significance or not. Then because ECG just tells about 10 seconds, what has happened in those 10 seconds. And a normal ECG does not rule out any disease, and an abnormal ECG does not tell the patient has some problem right now. So ECG may not be that sensitive or specific as far as the immediate diagnosis are concerned. So, and after the ECG, we are doing a recording. Everyone must have heard of Holter monitoring, where we can record the ECG for 24 or 48 hours, or sometimes even for 72 hours. As you increase the recording of the ECG, the duration of the recording of the ECG, I think we can pick up a lot of arrhythmias. Otherwise, they cannot be seen on the ECG. So we have got, I think, now we have got Holter monitoring, which can be done even for 3 days. Then we have got patch recorders, where we can put a patch on the patient. Patient can move around, and the recording can be done for 7 to 14 days. And then there are event recorders. If there is any event is happening, patient immediately presses the button. The event can be recorded and can be transmitted. So those are event recorders. Then there are handheld devices are there, where if there is anything, if the patient is having a device, he can transmit the ECG by holding the device in his hand, and that ECG can also be either can go, if it's can go to his smartphone, or from his smartphone it can go to his treating physician or cardiologist. So there are a lot of things which are happening as far as recording of ECG is concerned. And I think if the patient is having a pacemaker, or if we can put a internal loop recorder, there is a small device is there which can be put under the clavicle, very small procedure, which can record the ECG for 1 to 3 years. So especially people who are having stroke, cryptogenic stroke, and we suspect that patient is having underlying atrial fibrillation, and we want to really document it, and which cannot be documented on ECG or Holter or even on patch monitors, and we strongly suspect that patient may be having underlying atrial fibrillation, then we put that internal recorder. So that these are the certain developments which are there as far as devices are concerned. But I'll be talking to you about what the ECG, what it holds in the future. And if I show this ECG to anyone, even Dr. Shishir is there. If this ECG is being shown to anyone, even cardiologist, they will say this is a normal ECG and there's nothing wrong with this ECG. Good morning, ma'am. Good morning, ma'am. I think you have entered at the right time. My future of the ECG starts here. So I was telling to you that if this ECG is being shown to anyone, they will say this ECG is normal. But if I submit this ECG to my artificially intelligence trained computer, and the computer will say this ECG is of a female, she is a 55-year-old female, she had a normal LV function of more than 45%, her potassium is around 5 milliequivalents per liter, and she had an episode of atrial fibrillation in past. You will say Dr. Gupta is talking nuts. How this can be said, but this is what's going to happen in future. So if we train our computer by artificial intelligence, by so many, I'm just giving you a few examples, but this is what's going, ECG is being fed to a computer, and computer will give so many things. These are just a glimpse of the thing. So how it happens, this is the latest technology to train the computer systems to deep learning processes. And there are three processes are there. One is the training, the other is internal validation, and third is the testing. So these are the three steps. And for training, I think I'll give you lakhs of ECG. It's not 3 or 4 ECG. Lakhs of ECG of males are being fed to the computer. Then lakhs of ECG of females are being fed to the computer. And then the computer identifies, which we cannot see from our naked eyes. But he identifies that there are certain things which are specific for male ECG. There are specific things for female ECG. So then once the computer learns about the ECG, then we submit another lakhs of ECGs to the computer to identify whether computer is identifying the sex properly or age properly. Once you are convinced that yes, the computer is identifying almost 80 to 90% properly, then we submit the testing ECG. You take any ECG, submit, and the report is comes out. So this is how the validation. So just to tell you about this study where about 5 lakh patients ECGs were fed to the computer, 4 lakh ECG of training set and 1 lakh ECG for internal validation. The mean age of the patient were about 58.6 years and 52% males. And then about 2.7 lakhs ECGs were fed for the testing sets. And even some for seeing their chronological age differentiation, some multiple ECGs of the patients were fed to the computers. And overall accuracy of sex differentiation was 90% for females and almost 90% for males, and overall 90% for male and females. And sex determination was more accurate for younger patients, because in younger patients we have got hormonal changes between males and females. But after the age of 60, 65 years, almost the hormonal changes are not there, which may affect the ECG, which we do not know. So if the sex determination was more accurate for younger patients less than 45 years of age as compared to the patients who are more than 55 years, 93% versus 89%. And the ECG identified not the chronological age. Like if I'm 70, it will not identify you are 70-year-old. He will tell you either you are 63 or 77. So it identifies the biological age. So if I'm 70 and computer says 77, that means my time has come closer. So that's how the computer doesn't tell about your chronological age, it tells about your biological age. And similarly, the computer, I have told you that the computer can identify the asymptomatic LV dysfunction, because asymptomatic left ventricular dysfunction is common in elderly population and is approximately 3 to 6% in general population, and it leads to increased morbidity and mortality and reduced life expectancy. Again, more than 6 lakhs patients were selected, and patients were subjected for training, internal validation, and for the testing set. And the mean age of patients were around 62 years. And in the testing set, almost 7.8% the ECG identified the ejection fraction less than 35%, and about 12.7% identified the ejection fraction between 35 to 50%, and 40,000 ECGs or 80% showed the ejection fraction more than 50%. Now, overall accuracy again for identifying the LV dysfunction was around 85%. And patient with no comorbidities, if some patient is just having normal without diabetes, hypertension, etc., the accuracy was more. The overall accuracy was around 92%. And certain ECGs, they said that patient has got asymptomatic LV dysfunction, but the 2D echo was normal. If these patients were followed up in future, and people developed LV dysfunction, so the ECG identifies if we are going to develop LV dysfunction in future, so which no one can predict, but the ECG identifies asymptomatic LV dysfunction, which may happen in future also. And similarly, I was talking about the atrial fibrillation. I told you that the atrial fibrillation, sometimes we are suspecting atrial fibrillation in cryptogenic stroke, but we cannot identify in ECG, Holter monitor, patch monitor, even in internal loop recorder. But if you submit this ECG, it can say the patient had atrial fibrillation in past. So again, I have given you the number of patients which were more than around 4.5 lakhs ECGs were fed for training set and internal validation and the testing set, and it showed up approximately 8.4% patient had atrial fibrillation in past. And this the sensitivity and specificity was again 80%. And if we take the window period of 31 days, whether patient had atrial fibrillation last 1 month, the accuracy improved to almost 82% or so. So we are putting an internal loop recorder to record the ECG for 2 or 3 years. Here we in 10 minutes time that whether patient had atrial fibrillation in past or not. So the other areas where I think the artificial intelligence and ECGs are being looked is hypertrophic cardiomyopathy. From ECG, one can talk about whether patient is having hypertrophic cardiomyopathy or not, hyperkalemia, aortic stenosis, etc. So there are a lot of fields are there where one can use this artificial intelligence-based ECG interpretation. So just to summarize, electrocardiogram continues to be a critical component of the evaluation of patients who have signs and symptoms of emergency cardiac conditions. I told you about acute coronary syndrome and arrhythmias. The 12-lead surface ECG can indicate pathological changes even before structural changes in the heart can be diagnosed by other methods. Recording of an ECG is of great value for several past generations of cardiologists, and it continues to provide vital information. And artificial intelligence is going to change the total outlook of ECG interpretation. I think it's a very, very exciting field. Maybe if I'm not there, my children will see these. Thank you.
Any questions?
Thank you very much, sir. Any questions, please?
Please, sir.
The scenario, sir, is very scary.
It's not very scary.
Yes, sir. Artificial intelligence is going to take over medical industry.
No, not at all.
Yes, they will take over our medical profession.
Not at all.
It is not only ECG, other technical terms, and including investigations, they will take over. And some person will sit in a kursi and operate computer, and he will outsource everything. There will be no doctors.
I don't think that this is going. It's always the technology.
This is scary.
And it's scary, but no, it's not that the computers can take the human brain. Human brain will always be superior because we are making computers
exactly.
artificial.
They cannot be superior. We are creating this. Artificial is being created by human being only.
Yeah,
but see the scenario. Everything is being taken over by artificial intelligence.
I think any new technology comes, we are scared, but I don't think we have to be scared. We have to use these things to help.
Sir-
Otherwise, suppose I ask you something. Suppose if a patient
see the future.
I'm just asking you one thing. Suppose if you see a case of cryptogenic stroke and you want to diagnose want to diagnose atrial fibrillation, how you will diagnose?
Sir, medical profession will not survive unless we see the things in proper perspective. You are seeing this is a very exciting technology or exciting option, but I see the future that there will be no doctor. Some person of that intelligence will sit in with a laptop or computer and he will operate. The whole industry is not, we do not require at all.
I don't think this will happen, at least in
So
our
you are very
generation, it will not
optimistic,
happen.
sir, but you are very optimistic, but I am not.
Yeah.
Whatever, madam.
Yeah. So, please,
Sir, how much do you rely on, now we get so many patients who will come with these alarms on their Apple watches, on their smart watches. Do you think that the ECGs on these watches should be used? Do we
No.
advise it to patients, and how much do we take these alarms seriously?
I think these patients who send, one thing is, again, whenever you get an alarm or whenever patient sees the alarm and send the ECG, it is again, we have to interpret, and we can always classify these patients, whether this patient belongs to the high risk or low risk after seeing the ECG, and if patient belongs to the high risk, and if the ECG tracing which has been sent to you says it's an atrial fibrillation, maybe we can try to again reconfirm the diagnosis, but we know this patient is having problem, and we are suspecting the problem, and the ECG is the transmitted ECG shows atrial fibrillation. You are sure that this patient needs our help. But if the ECG which has been sent to you does not classify the same diagnosis, I think there all those things have to be seen. But 80 to 90%. The ECGs which are being transmitted by Apple watches are correct. Correct. Yeah.
Sir, one thing I want to tell. Actually, ECG it's only the basic tool. It's the basic tool, and we should, with the recent inventions, we should go forward for other modalities. It's only the basic.
Yeah, it's a basic tool.
Yeah.
But I think the basic tool in future is going to let you know so many things which we are not aware of. So that is the basic thing, because so far we just see it's a normal ECG and we say you don't have any problem. But there are so many things which are hidden, which we cannot see.
Sir, another question, sir. AI can be a teacher. Actually, it can set the parameters to find out the new techniques, to predict these things, abnormality in the ECGs, which we cannot see normally.
Yeah, that's what I said, which we cannot see.
But whether you can find out that these are the new parameters which you can detect for a dysfunction, for these things, you can look up for these things. So over the period of time, they can teach us actually.
I do not know what's basically your question, because
Sir, normally we cannot see some of the changes, sir, but the AI is predicting. But after some prediction, so whether we can ask the AI what are the parameters you are used to predict this particular pattern,
how it's predicting, there are, the basics are there. I have not touched those basics. How the AI is predicting all these abnormalities. It's a
Yes,
basics of the ECG, because the computer reads in a binary manner.
Yes,
There are certain 3 digits are there, and based on the ECG of males or females, there are different digit codes are there, and based on those codes, the ECG, the computer is telling whether this ECG belongs to a male or female. But artificial intelligence telling you by which way you shall diagnose the LV dysfunction, etc.
Yes, sir,
Maybe because we have to diagnose LV dysfunction at the moment, we have certain tools are there, whether we use echo, MRI or anything else, the PET scan. So that maybe in future they may also tell you so many things, and it becomes more and more scary.
yes.
Thank you. Thank you very much. Yeah.
Yeah, I request Ashok sir to hand over a token of appreciation.
Yeah, congratulations for a good talk. And I just want to know, as you mentioned about the gender-based ECG, does it make any difference in the management?
It doesn't make too much of difference in management, but yes, of course, we know that even coronary artery disease has got different way of presentation in male and different presentation in females, different presentation in so there is a difference as far as management is concerned because we know the males have got more progressive disease etc. as compared to females. So there are a few differences are there, and that again may tell you how to manage male patient with coronary artery disease who is high risk and females who may not be that high risk. So, yeah. I do not
Sir, just add to this atrial fibrillation in a male and in a female. So male has one more score than the female. So having cryptogenic stroke or atrial fibrillation, what we got, usually we don't got, we got in the ECG or ILR. So we'll have give more alarming to the male person. So has some disease was more prevalent in female, some disease was male. Thank you, sir.
Thank you,
Sir,
thank you, thank you, sir.
Sir, I request Ashok sir to hand over token of appreciation to Gupta sir. The next speaker is Dr. Nihar Mehta. I request chairperson to introduce Dr. Nihar Mehta.
Dr. Nihar Mehta, welcome to the podium. He is MBBS, MD Medicine, NB Cardiology, FRCP London. He has a glorious academic career, first rank in final MBBS and third rank in MD in Maharashtra. Currently, he is the Associate Director of Structural Heart Department, Jaslok Hospital. He is attached to various hospitals in Mumbai, Jaslok, HN Reliance Foundation, Breach Candy, Bhatia, Elizabeth Hospital, KJ Somaya, and Somaya's Super Speciality Hospital. He had special training in TAVR, mitral clips, and tricuspid valve interventions. He has performed the first AV synchronous micra, which is a leadless pacemaker in South Mumbai at Jaslok in November 2023. Performed the first TAVR in a transgender person in India on 9th November 22. Performed the first 2 mitral clip transcatheter edge-to-edge repair in Western and Central India successfully on 23rd and 24th August 21. Performed the first cable valve implantation in India in a patient with cardiac heart disease successfully on 10th April 2019. Multiple publications in index journals, editor and author of various medical textbooks, trained in taekwondo, martial arts, formal training in sitar, violin and piano. Welcome, sir.
So obviously all the medical achievements have no value. I mean, I only got applause with the taekwondo, sitar and violin, so maybe I should... No, thank you so much. It's a very kind introduction. I don't know where you all have got all this information from, but really kind of you. Thank you so much. So we will stay a little bit away from the music, but I want to talk to you all about TAVIs and choosing the right valve for the right patient. So when Dr. Shishir had invited me for this talk, basically, we decided that it should be more of a talk as to which patient should not only get the right valve, but also the right decision in terms of surgery, TAVI, medical management. So this is more like an aortic stenosis talk and less centric to the valves. I would first like to thank my TAVI team in Jaslok. Dr. Handa, Dr. Ashwin Mehta and Dr. Nikesh Jain are all part of our team, and the institution I trained in Hungary. So let me start by introducing aortic stenosis and introducing the problem to you all. You know, it is not only that this problem is a part of regular aging, but the extent of the problem is quite serious. Over the age of 80, at least 4 to 8% of people will start having degenerate aortic stenosis. And over the age of 90, over the age of 90, it goes up to more than 10 or 12%. Now, just imagine that once you've crossed the age of 80, 1 out of every 10 octogenarians is going to have aortic stenosis. And now crossing the age of 80 is a reality. We have so many people who are surviving because of all the advances in medical sciences. Also, what we should realize by this curve is that once patients they start developing symptoms, then the decline in their life expectancy and in their quality of life becomes very dramatic. And we know the dictum of 5, 3 and 2, that is once you get angina, syncope or breathlessness, your life expectancy goes down to 5, 3 and 2 years only. So once you start becoming symptomatic, your decline is very fast. Now imagine you have an 80-year-old who's got very minimal comorbidities. We have a lot of people who have very well-maintained lifestyle. Suddenly they get aortic stenosis and their life expectancy goes down, their quality of life goes down. If we can correct this aortic stenosis, they go back onto the curve of getting a normal life expectancy. So replacing the aortic valve is not just palliation, it is actually a cure for aortic stenosis. Now, in India, these numbers are the extent of the disease that we have. In our 1.3 billion population, above the age of 75, we have 27 million. And the incidence of severe AS in these is around 3 to 4%, which is around 1 million. Symptomatic will be 600,000. The ones who will be eligible for surgery will be at least 60%, which is 400,000. And the remaining would have earlier, 10 years back, got nothing. They would have just been left to be on medical management and they would have been condemned to a slow and painful death. But now these remaining, at any cross-sectional point in India, we have at least 280,000 people who are eligible for a TAVI. And that's why if you see this data which was published in Indian Heart, the number of this aortic stenosis and the interventions is going higher and higher every year. And that comes out of science. These trials, which I have summarized in this one page, all the way from partner, core valve trials, they went from high risk, intermediate risk, low risk, and eventually it's found out that TAVI is equal to surgery in all subsets of patients who require the aortic valve replacement. Now, why are we comparing this to surgery? Because we know that surgery initially was the gold standard. When we had nothing else, even an 80-year-old used to go for surgery because there was no other option. But now we understand that the outcomes are absolutely the same in all these categories. And because of this huge number, this is the number of valves which we have available for TAVI. The number, you can just see by the number of companies which have made these valves, is that the number of patients and the number of, eventually for them it's also commercial. So they make these valves because there is a large number of people who need it. And what I will start with telling you all is what do we do in a TAVI and what we do in surgery and how we select different valves for different patients. Because now patients, like I would say 5 years back when we had started the first TAVI, the first 2 cases of TAVI we had done in Bombay were, we had to go to the airport with the patient to import the valves because they were not made in India. They used to come from Germany or US. The patients had to pay 200% duty. We had to take special permission of on compassionate grounds to import these valves. So the first 2 patients, we had to actually go to the airport to do this. Now that this is done here, we understand that the simplicity of this procedure is why this has taken such a large, it's become a revolution in cardiology. So number one is that these patients are not put under general anesthesia. How we do a normal angiography is the same kind of setup and process that you have for a TAVI. It can be done in mostly any cath lab. The local anesthesia, maybe a little mild sedation. We put a temporary pacemaker from the jugular or the venous line, and we take both accesses, right and left femoral. This is the sheath of the TAVI valve going up, and if you'll see this, you will see a little wire here. This calcium that you'll see, I'll just get the, yeah, so the calcium that you see here, this is the aortic valve calcium, and this is the crossing of this aortic valve with a wire and a catheter. Subsequently, what we do is, on this, we balloon inflate and open this valve so that it can allow space for the new valve to come in. All these are concepts very similar to how you do an angioplasty. Now, the type of valves that we use are multiple. Now, I won't get into all the details, but the couple of the commonly used valves I'm going to show you all in a few details. Now, the decision that you all will be faced with is not going to be what, do I need to do a TAVI or not. Nowadays, people don't come and say, what is TAVI, is it a good process or not. Now, people will come and say, okay, I know that I have aortic stenosis, I've checked online, there's a procedure called TAVI, I want to know which valve is good for me, which procedure is good for me. So now the patients also, because of the availability of internet, are now Googling all these things, and we need to be aware of what is the basket of valves available in India today. Now, the Medtronic valve was one of the first valves which came here, and it has certain advantages. That is, it is recapturable. So when you're starting a TAVI program, it gives you a little flexibility to use the valve, deploy it, recapture it, and I'll show you all some cases about this. So this is the Medtronic valve which goes up, and based on the marker that is here and here, we deploy this valve at around 3 millimeters. Now, this valve, when it is put here, was very deep. This pigtail is a marker. This is the level you want it to be deployed at. This goes very deep, 6-7 millimeters. So this valve has the ability to be recaptured, and then you can reposition it shallower. If you'll see this is much shallower here, and therefore the valve this has a little margin of error. And then this valve was deployed and had a good result. Now, when Merrill came into the market, first we had no choice. We had only Medtronic available, and we used to do Medtronic cases. But I think Merrill, full credit to the Indian company, because they have changed the way that they have changed the accessibility of this valve all over India. It's a cheaper valve. It's an excellent quality valve. We've used multiple cases, and now they've gone on to have certain advantages which are different from any other valve in the world. And the most important thing about Merrill is that they have various sizes. Most of these valves come with 3 or 4 sizes. Merrill has every quarter or 1.5 centimeters, there's a different valve available. We visited their sites in Vapi, and the quality in which they are making these valves is fabulous. I think we should all be very proud of this company for what it has done. It's put India on the map in terms of TAVI, in the global map. And this is the Merrill valves which are being deployed. I just run these videos. So now Merrill has 2 kinds of valves. One is called octa-core, and one is the my valve. This is the octa-core valve which has been put up. These videos don't seem to be running. Nevertheless, the next is an Edwards Sapien valve. This was the first valve which was designed, and it has some advantages, especially with the flexibility of the sheath and deploying these valves. Again, this is the Edwards valve. The Merrill and the Edwards valve are the only balloon expanding valves. All the other valves are self-expanding. This is something called an accurate neo, which has the only advantage of it protects the coronaries with these hooks. And of course, there's a valve called Hydra, which is also an Indian company. Although it does have a good system, it still has some little bit of innovation is still required in this valve system to improve it. Now, as you all can see, I've shown you all some various cases where each of these valves looks different and valve has a different property. So it's important that we know some of these valves. We should know about the Medtronic, the Merrill, the Edwards. These are valves which are available in India, and we should know how they function for each patient. We should also know that some are better for some and some are not so good for the other. This is how a patient is post-procedure. This was the first patient we had done who was 88 years old, and the day after the procedure, he was standing and walking in the ward. Now, let's talk about surgery. Surgery is actually, like I said, it used to be the gold standard because in surgery, there are some advantages. When you go in for a low-risk patient, you actually remove the entire valve leaflets. So all the anatomical problems with the valve, too much calcium, bicuspid valves, everything is accessed by surgery. The valve is removed, the valve is replaced, and the patient goes home maybe 7 to 8 days later. Now, these are all the surgical valves available. Even in the surgery, there are stented valves, non-stented valves, there are externally and internally mounted valves. There are valves which have a graft, like a Bental's graft with it. Now, again, even when we are discussing with our surgeons, it's important that we have a discussion with them that what is the best valve for this particular patient? Is he going to require a second valve? Because all these valves have a life of 8 to 10 years. And we need to know how the patient is going to behave for the next 10, 15, 20 years of his life. So these discussions should be very clear with the patients, now with the surgeons as well. There are also valves which are now being designed surgically, which are conducive to TAVI later. Today you do a surgery, 10 years later, certain valves allow more easy TAVIs for a patient in case they need or in case they get regeneration problems. Now, why I've put this photo is not to dissuade you all from surgery. It's just to tell you all that there are certain differences between surgery and TAVI, and when we have to see a patient, we need to see them in total, not just the aortic stenosis and the echo. How frail is the patient? Because eventually surgery does have a certain recovery period and a certain morbidity, but this is not so that we feel that surgery is not a good option. If you're getting into a TAVI program, you do it without a surgeon next to you, it's a crime. Nobody should do a TAVI without a surgeon at least sitting in your cath lab with you, because TAVI is a team approach. You cannot do a TAVI individually. You need to have a good team for this. So we do ask patients now. Now when we see a patient, we see, are they a high-risk TAVI and should they be referred to surgery? And this should be a multidisciplinary team. You should have a TAVI patient, surgeon, the interventionist, maybe the echocardiographer, the anesthetist sitting in a room and discussing the CT scan with the patient. In JSLOC, we do this every Thursday. We have a meeting where we discuss every CT scan threadbare, and the surgeon sometimes tell us, look, this is a very simple case for me. Send him to surgery as compared to this, we may have some coronary obstruction in TAVI, which is why when you have that open discussion, you have a more exchange of patients and you have an overall better result for your particular patient. And remember, the patient preferences also should be taken into account here. Now, there are certain, basically for deciding, we need to decide between anatomical and clinical factors and lifetime management. So, in anatomical factors, sometimes we have issues like too much calcium. If you'll see this balloon, it ruptures. Suddenly you'll see the dye being lost because the calcium was too much. So this patient we luckily put a self-expanding valve because they are less dangerous for annulus rupture and annulus injury. Similarly, if you have too large valves, that is, if the annulus is too big or they are too small, then in these kind of situations, it is better to have a surgical repair at times because the valve flexibility or the choices of the valve sizes are a bit higher. But in case you have a large valve, then it has to be a balloon expanding. A Merrill has some very large sizes which no other company has. Anatomical factors like AR, sometimes you have no calcium. And in this kind of patient, you have to oversize the valve, for which you need a self-expanding valve. Similarly, you have sometimes risks of coronary obstruction. In these cases, it's important to protect the coronaries. Sometimes you have horizontal aortas, bicuspid aortas. I'm going to run through these slides because we are lacking time. A lot of peripheral problems can come in. Then I want to discuss, just the last couple of slides are on what is called lifetime management of TAVI, where when we see a patient at say 65, 70, we need to think of 4 or 5 things. Now 65-year-old will survive till 70, 75, 80 maybe. So at 65, we want to give him one outcome which will probably be lifelong. But that doesn't happen, because if at 65, whether he gets a surgical valve or a TAVI valve, at 75 he's probably going to need another procedure. So when we choose that first valve, whether it's a TAVI valve or the surgical valve, we should think about all these things. A 65-year-old may get an MI 10 years later. What about the coronary access through the valve? What about the pacemakers? You don't want to put a pacemaker in a very young patient. For these 2 points, the balloon expanding valves, which is the Medtronic and Sapien, are better. For PVL and hemodynamics, sometimes the flowering valves which I showed you, all the Medtronic valves, these have better hemodynamics and better gradients. So they probably have a better long-term outcome. For them, these kind of valves will be a better choice. And durability, meaning can these valves work longer? Can they work for more than 10 years? That is something which we are all working on. I think there is some surgical valves now called the mitralis valve, which does, on paper, at least have a 15 to 20-year durability in spite of being bioprosthetic. So to conclude, I would like to say that TAVI does have excellent and reproducible outcomes in terms of doing it in various kind of cath labs with similar setups that are available for coronaries. We need to see these patients as a group, see their anatomical features, and see if their access is favorable, see if their outcomes are equivalent to surgery. If we feel that the TAVI patient is going to have a poorer outcome than surgery, we have to be honest about this and send them for surgery. We have to think about their lifetime. When you see a patient, you should not say, oh, TAVI, simple. Like, you have to think, okay, now if I do a TAVI and 10 years later he needs a second procedure, what are we going to do? And this is the most important, that you need to have a group of a good group who's going to be part of your team and decide which is the best patient for the best possible outcome. So most patients can be candidates for TAVI, and high-risk TAVI patients should be candidates for surgery. So with this, I'd like to end my talk, and with a lot of thanks to the audience and to the chairpersons.
Thank you very much, sir. Any questions, please? Sir, I have got a question. Out of this subject, how come you got interested in this martial arts, sir? Because usually cardiologists, they are very soft.
Martial arts I used to do, I've done them all through my life. The only reason I stopped was my final MBBS. I didn't get time to continue to become a black belt, but otherwise it was, schools, from school days.
Very nice. Thank you, sir.
But it does help, because sometimes you need to do a lot of pushing and pulling during cath lab procedures also.
Yeah.
And it keeps, and nowadays, doctors need to protect themselves, so.
Okay, thank you, sir.
The main reason I think was he has to work with cardiac surgeons.
Oh, hi sir, how are you? So I'm actually happy. I didn't realize that sir is sitting in the audience, but it's good that I didn't put down the surgeons too much. No, but sir is actually part of the TAVI team in HN, and sir has been supporting a lot of TAVIs for the ones we've done. And sir will agree that there is no substitute for a good team and an honest approach of, look, this is a better case for surgery or this is a better case for TAVI. When that happens, your patients will benefit.
I think indications for TAVI are increasing day by day. Maybe earlier where we used to do TAVI only for high-risk surgery patients, those who will not,
we cannot send the patient for surgery, then we used to consider TAVI, but I think the indications are expanding tremendously for TAVI, and a lot more patients are being benefited, except I think for the cost of the TAVI and the surgical procedure is quite different. So if the cost does not permit, I think a lot of patients will be benefited by TAVI. But there are certain problems with TAVI, especially the conduction defects, etc. They are more with TAVI as compared to surgery?
Yes, sir. So actually, this is an important point you raised, because now we know that TAVI it can be done for any patient irrespective of risk. But this talk was actually to discuss when it should be done and when it should not be done. You have a 65-year-old patient who's very frail. They may be on paper a low-risk candidate, but they will be better for a TAVI. Similarly, there may be an 80-year-old who's absolutely fit and fine. He's got very bad coronaries, very bad triple vessel disease, and very calcified valves. Even an 80-year-old can go for surgery with a low risk. So that discussion should be very open. when we talk about pacemakers, the surgical risks for pacemakers are 1 to 2%, whereas for TAVI they are 5 to 10%. And this is again a problem which needs to be looked into in more detail. If we feel there are parameters we look at in the ECG which tell us that, look, the patient is a high risk for a pacemaker. And if that is the case, then sometimes that could be, if it's a 80-year-old who needs a pacemaker, it's very different. But a 65-year-old going home with a pacemaker, he'll need a battery change again after 10 years. So you're talking about condemning that patient to many, many different kinds of procedures. So all these things need to be looked into. Although TAVI can be done and executed very easily, but the decision, the CT scan, the evaluation, the heart team, when you spend more time on that, that's when your program and your procedures become simpler. Yes, sir.
Sir, I want to make one comment only, but this is not a question. That was excellent presentation, sir. I literally touched my heart. That is the purpose of this profession. You are targeting the population who are more than 65 years. You said 65 years. We are worried about those who are more than 70, more than 80. So you had keep that point, that sympathetic consideration, empathetic consideration. That person has to be taken into consideration because he is the person who is going to get benefited. So he should understand what is going to happen with him, not the relative and not the doctor.
Yeah, that's very true.
Definitely you have taken that into consideration. That is really what is doctor profession is made of.
So, sir, I'll tell you one thing, that there are two ends to this coin, two sides to this coin.
Right.
Because yes, now we know TAVI is available and all. Anybody who's doing TAVIs will also get a 40, 50-year-old who will come and say, I have aortic stenosis because of a bicuspid valve. I don't want surgery. I want to do a TAVI. But trust me, that's not a good option for that patient. In 5, 6 years, for a younger age group, if you do a TAVI, they degenerate very fast.
Right.
In 5 years, at 55, 56, if you have to do a second procedure for them, that's a very, very big risk.
Very big risk.
All our surgeons here will tell us that once you've done a TAVI, suppose they've done a TAVI at 50, at 60, if they degenerate, and I tell the surgeon, now go operate and change the valve. Taking out a TAVI valve is very, very difficult because the TAVI valve sort of, it encroaches and embeds into the valve. Into the wall of the aorta. So it is very challenging. So at 50, a patient will come and tell you, I don't want a surgery, I don't want a scar, but it's our job to convince them also.
Right.
And therefore, this patient consideration should be considered not only from the point of view of comfort, but also in the view of longevity.
Right.
Thank you.
Thank you, sir.
Thank you, Dr. Nihar. I request Simi ma'am to hand over a token of appreciation.
This excellent talk by Dr. Nihar, and this session is sponsored by Merrill Life Science India Private Limited. It is our own product that is from India, Merrill Life Science.
The next speaker is Dr. Ajay Pandey, cardiac surgeon, Jagjivan Ram Hospital.
Dr. Ajay Kumar Pandey, he is a senior DMO cardiovascular thoracic surgery at JRH. He's done his MBBS and CVTS. He has got 3 years experience as an associate consultant at Sri Sir Gangaram Hospital, Delhi, and 1 year as a consultant at Fortis Hospital, Delhi. 2 years working at Railway Hospital. His special interest is coronary surgeries and minimally invasive cardiac surgery, pediatric cardiac surgery. Then he has got publications, total of 7 papers in various national and international journals. Thank you, sir. Go ahead, please.
Thank you, sir. Thanks for your kind introduction. Thanks for giving me the opportunity to speak. Okay. Started now? Topic given to me is cardiac surgery currently at 2024, and what is going to be beyond. Let's hope I do justice to this very important topic. Going ahead. Slide is not moving. Excuse me. Excuse me. Slide is not moving. इससे control है क्या? ऐसे करो, ठीक है. Today, what's there today and what is going to be beyond. First, I'll take. नहीं मूव हो रहा है यार, आप उस पर ही कर दो ना. सीधा ऐसे नहीं कर सकते. This slide demonstrate what was cardiac surgery 70 years back, when first cardiac surgery, open heart surgery, was done in 1953. The OT was full of people. The operating, it's not there. Operating table was full of people, and there were so many surgeon and anesthetists. But now, what is today? What is going beyond the robotic cardiac surgery OT, where surgeon is sitting separately, patient is placed in a separate cart. They are just joined by few wires, and surgery is being done through the looking at the screen. So the cardiac surgery has come a long way. This development has occurred in all the aspect of cardiac surgery, be it cardiopulmonary bypass, the cardioplegia, the valves that we are using. The invasiveness has come down. First, to start discussing about the ischemic heart disease. The burden of ischemic heart disease in our society is increasing. Cardiac CABG, the basic surgery, the bread and butter surgery, it has come a long way. Earlier, the choice of it has to be when start total venous CABG. Then it became Lima vein CABG came in vogue, and now it is total arterial CABG and hybrid CABG. Hybrid CABG is not that used, but it is also there, where a portion of right side is dealt, or one of the vessel is dealt using PTCA, and the other are grafted using minimally invasive technique. Modality has evolved. Earlier it was more common was arrested heart CABG, but now it is more of beating heart CABG. Off-pump CABG or beating heart doesn't involve arresting the heart. And then total arterial grafting, it is use of internal memory artery, bilateral, left internal memory artery and right internal memory artery both, and with or without radial artery at times. Using total arterial grafting gives a longevity to the graft, and it is more commonly used in patients who are young. In fact, it is now given to even old patients. This is the conventional CABG on the left side, where vein graft has been used for the right, and then the total arterial, where only the internal memory artery bilateral has been used, and the radial artery has been used for the right side. In fact, both the internal memory artery can be used in different fashion to graft all the vessels on the heart. Now, about the conduit that is harvesting. Earlier it was, in fact, now even we are doing more of open harvesting, the radial artery as well as the saphenous vein. Often around 2 to 3% times it can lead to bad scars or non-healing wounds in this form. In order to circumvent this, and there can be bigger scar like sternotomy scar and bilateral radial scar, In order to decrease this, there are newer techniques which has come where vein harvesting is done using minimally invasive, using a single incision, using a single endoscope fitted with a prism-like dissector in the front, and CO2 insufflator is used in order to dissect the vein, and just there is a single scar on the leg, and it's excellent healing and good outcome and early mobilization. Now similarly for sternotomy, minimally invasive cardiac surgery has come to avoid sternotomy and complication. It is like left anterior thoracotomy, but now slowly people are left anterior thoracotomy, people are going to total endoscopic CABG, and robotic assisted CABG is going to come. Conventional sternotomy looked like this. People then tried to decrease the invasiveness, upper hemi sternotomy. Now we have gone for the scar which looks is hardly visible, right anterior thoracotomy scar, a left anterior thoracotomy scar, and in fact in the axillary thoracotomy where the scar is not seen only. Now all different type of, in fact all type of cardiac surgeries can be done, be it mitral valve repair, replacement, tricuspid valve, aortic valve replacement, congenital surgery like ASD, then atrioventricular septal defect closure, CABGs can be done by using this minimally invasive technique. The advantage is better looking scar and less pain, less early healing, and early return to the work. Traditional approach has prolonged healing time. We have to keep our employees at least sick for minimum 1.5 to 2 months because sternotomy, bone healing takes time, and they are not amenable to lift weight and all more than 10 kg, 15 kg. So we advise to go back after CABG at least 1.5 to 2 months after surgery to go back on work. This can be avoided using minimally invasive approach. For minimally cardiac surgery, we require separate set of instrument, and with the help of this, we have got this in last 1 year. And these are long instrument. Since the heart is dealt from the side, it needs the long instrument to be used in order to do surgery. It has to be done through a small incision. This is like right anterior thoracotomy, mitral valve replacement being done, mitral valve. This is the exposure to the Sondergaard group between the right atrium and the left atrium. And these are the cannulas are shown, which is to go on bypass. This is the exposure of the mitral valve for mitral valve repair or replacement. And post-surgery, this is the scar. In fact, in female, the scar will not be visible. It will go below the breast fold. And our data just wanted to put in perspective, since we have got this instrument in last 1 year, we have been able to do 12 cases, off-pump CABG 5, ASD closures we have done 2, aortic valve replacement 2, few have done, and VAT surgeries also we have started, 3 cases in last 1 year we have been able to do. Then this is the MICS CABG video, the harvesting of left internal memory artery being done in our OT. Then from minimally invasive, now people are moving toward robotic CABG. Robotics, minimally invasive involves a scar, some around 4 inches to 6 inches. But now robotic CABG will have only 1 centimeter port insertion. 3 to 4 ports have to be inserted, and the surgeries can be done. It involves, there is a separate cart, surgeon's cart is there, sitting at one corner of the OT. Table is at the different corner. The patient cart looks like this, where the patient is on the table, and there are 4 to 5 ports are there to put the instruments. It is manned. There is a staff near the patient cart, and the surgeon is sitting separately on a console, and he is operating remote, in the same room. When in robotic assisted surgeries, the robotic can be used for a myriad of cases like mitral valve, CABG, removal of cardiac tumor, congenital surgeries also it can be used. And then for thoracic and lung surgery also it is very commonly being used, lobectomy. In fact, it is more used for these cases, and now it has come, it is being used for cardiac surgery cases also. Then advantage of robotic is, the robotics as compared to MICS is, it is an excellent 3-dimensional and magnified vision is seen, and better depth perception is there. The movement of the robotic arms are more precise and fine. It gives a tremor-free movement, provides ambidexterity, and there is no fulcrum effect as seen in MICS because of the long instruments. Then it has got multi-joint endorist. It allows better movement in small spaces as compared to MICS. And most recent robotic system has got additional arms where you can put retractors and in through them. And benefits of these robotic surgeries are reduced post-surgical infection, less risk of stroke, bleeding, and infection, which is the most common complication for surgeries, bypass surgeries. Lower in-hospital mortality rates, faster recovery time, very small incision involved, and reduced complication of anesthesia. Now going ahead, what is the new thing in valves? Already, sir, before me, sir has already described about TAVI and all. I'll take you through. For too old and too frail patient, already described TAVR, TAVI or TAVR is there. I will tell more about the surgical aspect that is involved in this valvular heart disease. I'm going through because already have been described. This sutureless valves are the newer valves which are being used, especially in high-risk cases where the patient is not fit for prolonged CPB, where this sutureless valve can be implanted in a very short time, quick time, and you can come off bypass. This is being used now, and it has got better profile and better durability. This can be done using mini SAVR, using minimally invasive approach. There is a good implantation speed, reduced CPB time, reduced aortic cross-clamp time, and shorter ICU stay and length of hospital stay. And then it can be used in also hostile routes where there is calcified, the route is very calcified and may not be very amenable for full surgical aortic valve replacement. Now, going ahead, certain innovation that has taken place in pediatric cardiac surgery. Pediatric cardiac surgery is a separate challenge. Replacement in them is very difficult because children are going to grow. You replace at around 3 years of age, suppose, and then the valve or the conduit which you have will be insufficient after 3 to 4 years. How many times will you replace? That's why the more and more newer techniques of aortic valve repair and mitral valve repairs are being used. People are stressing more for Ross procedure, wherein the pulmonary valve is put on the aortic position for aortic valve, which is more important, and homograft is used for the pulmonary position. Similarly, the newer technology of AI is being used for management, perioperative management, where these monitors are using AI. We can predict well in advance if there is any adverse event that may happen. Hybrid therapies, wherein the surgeries are avoided by using, especially in TOF patient, later we can put a P valve, where the pulmonary valves can be replaced, for whom the pulmonary valve insufficiency is there after TOF surgery 3 to 4 years down the line. Tissue engineering, stem cell and regenerative medicine and mitochondrial implantation is being used in order to get a valve or a conduit which will grow with the patient. And 3D modeling and printing is being used for difficult anatomy patient where difficult repair is anticipated. This is being used in order to study the pathology. This is our modest experience this is the case which we have done in last month only. I just wanted to showcase for the people to know that we have also doing pediatric cardiac surgery. And total in last year, we have been able to do 8 surgeries, sinus venosus ASD 2, ostium secundum 5 and VSD closure 1. Lowest weight that we have operated is 8 kg and lowest age is 3 years, but gradually we are trying to make it more complex and coming to lower weight also. Now VAT surgery, just to complete, to know that this is being minimally invasive surgical procedure for lung and other organ in thorax is being done. This was our thymectomy case. This thymectomy case that we had done, the port incision, it also involves using port like that in VATs, but it is more of using what is called as a thoracoscope. Common surgeries that are being done, bulectomy, lung volume reduction surgery, then correction of spontaneous primary pneumothorax, lobectomy, pneumonectomy, lung parenchymal biopsy, and wedge resection. Our own case of VATS thymectomy that we did in JRH in this year only. I just wanted to show you the short video. Going ahead, something which is now growing fast. In fact, our speaker later is going to tell about these problems. The mechanical circulatory support. The mechanical circulatory support is supporting the heart when there is a heart failure. When the drugs have proved to be inadequate, these are the support which is being used. Heart transplant is not easily available due to the concern, the less availability of heart. There is a large waiting time. But patient may be getting sick and may be getting admitted, readmitted a lot of time. They can be tied over using mechanical circulatory support. The indication is cardiogenic shock after acute myocardial infarction, cardiogenic shock after cardiotomy, myocarditis, refractory ventricular arrhythmia, chronic advanced heart failure. The strategies that is used for mechanical circulatory support is till the patient is waiting for transplant, this support can be given, or it can be given as a destination therapy who is going to be unfit for transplant, or bridge to candidacy till he becomes candidate to become a transplant, to go for transplant, bridge to decision and bridge to recovery. Types of device that are available are short-term and long-term. Short-term, there's a tandem heart, a Biomed, Impella. These are the various devices that are available. Long-term devices, total artificial heart, axial pulsatile flow devices. Third generation device, HeartMate is available now. Long-term devices, these are the, so many devices have come in order to support the failing heart. I just wanted to show this one, where an electromechanical device is fitted into the LV. It takes the blood from the LV and it pumps into the aorta, and thus it helps the failing LV. And it is powered by externally, these are the batteries which are powering this pump. So this has been shown. This is to assist the patient till he gets to transplant. And in fact, now total artificial heart is being studied, and it is being in fact available in Germany, where the patient's native ventricles and valves are explanted. Instead of ventricles, this total artificial heart is placed, and it takes the blood from RA to the RV, and it pumps into the pulmonary arteries, and then from the LA to it goes to the LV, and it pumps into the aorta. There is a total artificial heart. And then something about ECMO. ECMO is the extracorporeal membrane oxygenation, where it is used in the patient who have, there is a heart failure and in fact respiratory failure. This is being used. We have our own ECMO in our department. And ECMO circuit flow is optimized, provides adequate support in the absence of native lung or heart function. It is instituted for management of life-threatening pulmonary or cardiac failure, where no other form of treatment is likely to be successful. Then it can be instituted in emergency and urgent situation after failure of other treatment modalities. It can be a temporary, it is usually a temporary support, usually awaiting the recovery of the organ. Just to complete, last slide. There are VA ECMO is used for cardiac failure patient, and VV ECMO is used for patient with respiratory failure, ARDS, and failed lung transplant. This is what I wanted to tell you about this, what is beyond in cardiac surgery. Thanks.
Thank you, Dr. Pandey, sir. Any questions, please? Yeah.
Patient care and patient options are concerned. Now in railways, as medical examiners, when we have candidates who are coming, who have undergone these kind of surgeries, it becomes very difficult to spot them. When we have long scars, it was easier for us to pick them up. Now when they have these minor scars, you please give us some tips how to catch them.
You have to take history, that is what you can say. There is no other way. Huh? Declaration. It is good for a patient, at least he is able to, there is no stigma or no scar, so it is good for the patient, for patient perspective.
Sir, I will congratulate for you the presence of ECMO. I had 2 or 3 patients who had to go outside, and it's not really available in private hospitals also. Only problem will be if I want to transport that patient to your center. I am at Baroda. There are some people from Rajkot and some from Bhavnagar, some from Ratlam. How do I transport that patient to you? This is one question. Second is pediatric. I am a pediatrician. I will be more oriented to your pediatric side. Can I confidently refer any of my pediatric patient to you and you will take care of them?
Sir, we are taking care of it.
That is second question. Third is, there are triple vessel disease in many patients. From my experience at Rajkot, presently I am at Baroda, there also, what cardiologists do, with due respect to Dr. Shishir and all, they find out triple vessel disease, they will find the most important vessel, they will stent it. They will keep the patient in the ICU and call back after 24 hours, sir, other 2 vessels are also to be stented. So if there is a triple vessel disease, the best option is bypass surgery. Why should I go for stenting?
Shishir sir should take this question.
No,
rather.
this question is directed to, I have not asked Shishir, you just give me a reply. Who is superior?
I think there is
No,
a guideline.
Shishir, please you respond after, let him reply first.
Actually, obviously, in fact, I can tell what is happening in our department. There is more or less heart team and there is a discussion that what is going to be best for this patient. And obviously, there are places where things are going on. There are many times when patient doesn't want CABG. What the cardiologists are forced to offer them, what is the second best option.
I am in a fix when they ask me, should I stent the other vessels? What I am supposed to say them? What I am supposed to tell them? Honestly, I do not know, I am not a cardiologist.
Sir, I think, sir, yesterday I had taken this class. So, triple vessel disease does not mean that the vessel is of this amount of length, you need 10 stent. So, even if single vessel also can you need CABG because long diffuse lesion, left main disease,
Right.
a triple vessel having a discrete lesion of 2 mm, 3 mm, we can put. So, there is a guideline. I am not having my own guideline. So, there is a guideline which patient has to have upper hand of PCI or CABG. And nobody does this blindly. We explain the patient, yes. However, patient choice is final. But there are some patients, even in a single vessel, we put the CABG, we offer the CABG left main. Even if we put discrete lesion, LED 3 stent small, we could say PTCA, not necessarily triple vessel CABG.
My purpose was different. I do not have any doubt about your integrity or your team performance. Should I refer those patients to you?
Yes, sir, we are definitely, we would.
And how do I transport a triple vessel disease to who is
Only when the patient is stable can be shifted, sir.
Exactly.
Only if it is
so
stable.
I will tell them, you stent one vessel, after that you shift them to...
Sir, even if patient, is unstable, you cannot shift from Baroda to your Rainbow.
Exactly, that is the problem.
So that I cannot even shift to the patient to nearby hospital also. Think of, so when patient is shiftable, you should shift. If not shiftable, you treat
That
there.
is
That's
also not
why
the question.
DG ma'am has given permission for an panel.
Should he stent at least one vessel को stent करके देने के बाद CABG कितने दिन के बाद कर पाएंगे?
So that's why yesterday I told now which is the infarct related vessel, which vessel creates the problem. Not ki at a single point of time all vessel will be infarct related. Everybody will present you. So the vessel from ECG, from echo, from clinical presentation, we see which vessel has the culprit now. We treat that vessel and now take care of the next vessel in next index or index.
Sir, one more view.
After that I will shift.
Yeah, please.
Dr. Ajay, can I ask a question?
Yes, sir.
I wanted to know what is your take on the use of lima-rima as conduits versus using venous grafts, because I understand that it's simpler, faster to put venous grafts, but lima-rima, using the lima-rima conduit is more better in terms of long-term outcomes. And second is when you're using minimally invasive approaches, is it possible to do lima-rima?
Yes, even with minimally invasive approach, lima-rima is being done. Obviously, I don't have experience and we are not have not done it here. But definitely what I have seen and what other, in fact, my seniors here may tell you about, ki it is lima-rima or lima radial, and a total arterial that is being offered using minimally invasive approach also, and robotic surgery, increasingly with robotic surgery, because it is easy to harvest lima and rima using robotic approach. Minimally invasive approach, obviously there is some surgeon may feel some backache and all. Total arterial, it has been found that it is better, but what is going to be the second, lima LAD is established. There is no second thought to it. It is the best option. But what is going to be the second conduit of choice is still debatable. People go with right internal memory. Then there are people, school of thought, which promote radial artery. And definitely arterial has been found to be better than venous.
Yeah.
That is one thing we established. Okay. So second choice of conduit still is debatable, but some go for radial and many people go for, especially in Mumbai, go with the right internal memory.
Thank you, sir. We are running short of time. Thank you very much.
Thanks a lot, sir.
I request Dr. Ashok sir to hand over a token of appreciation to Dr. Ajay. Our next speaker is Dr. Kamlesh Jain sir. The topic is CABG in young, today and tomorrow.
Kamlesh Jain. He is a cardiothoracic surgeon, worked at Nair Hospital and KM Hospital for 15 years. And now he has rich experience of 23 years in the field, and he has a special area of interest is total arterial revascularization, LIMA and RIMA on beating heart, minimally invasive cardiac surgery, TAVI, then aortic aneurysm surgeries, pulmonary endarterectomy for pulmonary thromboembolism and TAVR. He started immediate minimal invasive cardiac surgery and TAVR program at KM Hospital. He is the first cardiac surgeon in Mumbai to do TAVI successfully. Very good, sir. Then he has trained multiple doctors in TAVI. Thank you very much, sir. Please go ahead, sir.
So, good morning, everybody. Today, I am going to talk on CABG in young patients, and that is also today and tomorrow. So, one of the most daredevil surgeon from the 19th century, Dr. Theodore Bildroth, has once stated that any surgeon who will operate on heart or the great vessels will lose respect from the colleagues. But since then, the progress in the cardiac surgery is so phenomenal that we have moved from a conventional cardiac surgery to minimal invasive surgery, robotic surgery, hybrid procedure, as Ajay said. So now I just want to tell you about the CABG. What is exactly the CABG? So CABG, we started CABG, cardiac surgeon started CABG almost 8 decades back. And if you go to the history, so Alexis Carrel, he did an aortocoronary collateral in a dog. Then Dr. Wienerberg, he first connected LED into the myocardium, not to the vessel. Then in 1964, Dr. Kolesov, he did LIMA to LED. Dr. Green, he promoted LIMA. And then there are definite survival benefit of LIMA, which was been highlighted by Loop, Little, and Cosgrove. Radial artery was used by Carpentier, and bilateral thoracic artery, internal mammary arteries were promoted by K. So as we all know, CABG is a gold standard, and it is mainly because of a LIMA LED anastomosis. We all know that it is LIMA LED anastomosis gives rise to the lower incidence of reinterventions, fewer myocardial infarctions, lower incidence of angina, and lower associated mortality rates. And it is one of the procedures with the highest impact in the history of medicine or surgery. And there is no other operation which has led to more lives prolonged and better characterized with respect to its short and long-term outcomes. It's a keystone of adult cardiac surgery. And most importantly, it is evolving and the most durable means of revascularization. So now I'm going to talk on a CABG in young adults. So young means if it is less than 40 to 50 years of age. So that is what I call it as a young patients. So now there are challenges. There is a difference between the young and the old patients. So patients which are less than 45 years. So there are challenges in doing CABG. So what are the challenges in that? So first is diagnosis. Diagnosis in case of a young patient, usually this presentation is very difficult. There are very atypical symptoms presentation in case of a young patient. And second thing is acceptability or the suspicion of having a coronary artery disease in young patient. Usually we consider that patient is having acidity or some other things. And that's why we ignore the coronary artery disease. So first challenge is diagnosis. Second is risk factor. There are multiple risk factors like genetic predisposition, lifestyle choices. There are difficult, today's generation is having a different lifestyle choices. And third is comorbidities like diabetes. Diabetes is very common in India, and other risk factors are associated with the young patients. Now, once diagnosis is done, now what is the treatment? So again, making decision in case of young patient, whether this patient should go for interventions or this patient go for surgery. So treatment decision is also difficult in young patients. Most of the times cardiologists or the doctors say, you are young, you can go for a intervention right now, even if it is a triple vessel disease, and later on you can go for a bypass surgery. But then making decision in such patient is difficult. Depending upon the treatment, suppose patient opts for surgery, then what should be the choice of surgery? Because these patients are young, they are going to live for 3 to 4 decades even after surgery. So selection of a conduit is very important in this patient. So aim of any surgery is there should not be any re-intervention in the future. So we should use a conduit which should long last, and there should not be any chances of a re-intervention in the future. So longevity of a grafts is important while selecting the patient and opting him for the surgical conduits. Psychological impact is very important in young patients. So we should consult psychologists in this case. Lifestyle modification after surgery also is very important, and follow-up care, not even the surgery, follow-up care is important because this patient has to be followed up for 3 to 4 decades after surgery. So this requires a multidisciplinary approach including cardiac surgeon, cardiologist, and a psychologist. So what are the treatment options available in this patient? First is intervention. So intervention, of course, as you were, somebody was asking if it is a triple vessel disease, it requires a syntax course to decide whether this patient should go for interventions or CABG. If the syntax score is less than 22, this patient should go for an intervention. If it is more than 22, then this patient can go for surgery. It depends upon the calcium score. Now, thing is, even if it is a single vessel disease, if it is a diffuse disease, if it is a LED ostium disease, if it is a Lefman disease, this patient should go for CABG only, because even after 50 years, 100 years, distal Lefman is going to be the surgeon's area only. If it is a osteal disease, this patient should go for surgery, because this area is difficult for intervention, even if it is a single vessel disease. But if it is a triple vessel disease, patient is not having significant comorbidities, focal lesions, syntax score less than 20, this patient can easily opt for intervention. So I think I should answer your answer. So interventional techniques are one of the options available. Second is, of course, surgical. So intervention and surgical. Surgical, I feel surgery is the best option because it gives long-term results, and that is what our aim is. We should give long-term results. This patient should not come for intervention. Suppose if we do, there is a diffuse disease, if we go for this patient opts for intervention, and if there is a blockage in the future, maybe after 10 years, this patient blocks. So aim of our surgery is to preserve the LV function. The intervention, if it is get blocks, it reduces the LV function, and at that time offering that patient for surgery, it is riskier. So that's why opting the proper treatment choice is very important in young adults. So surgical is, what are the options available in surgery is a traditional CABG, what we do on pump or off pump CABG, then minimal invasive and a robotic surgery. Graft selection is very important. As I said, Lima to LED is standard, but of course, total arterial grafts is the answer for long-term results in case of young patients. So if we do Lima-Rima, that is gold standard. Even if we go for Lima radial, that is also better. But Lima-Rima, I think it is the gold standard in young patients. So we have to decide about the individualized treatment plan for the patient. It depends upon the age, disease severity, comorbidities available, comorbidities present in the patient, and the lifestyle of a patient. And after surgery, the rehabilitation and the lifestyle modification is also very important. He has to stop smoking, tobacco chewing has to be stopped, regular exercise, healthy lifestyle, remaining activity, taking proper medicines, and doing regular follow-up are very important in a post-op period, and long-term monitoring. So as I said, the basic aim of any revascularization, whether it is intervention or surgery, is to preserve the LV function, and it has to be long-term. And I feel that bilateral internal mammary arteries are best suited for the job and for the long-term results. So I'll just want to show you one video. So this is the Lima Rima video what I am doing right now. What I am showing, this is the right internal mammary artery. This is left internal mammary artery. Here I am doing a Y. So this is the cut in the left internal mammary artery, and this is the anastomosing right internal mammary artery to the left internal mammary artery. So now this is on a beating heart. We are anastomosing Lima to diagonal artery. I'm sorry for the quality of video is not that great, but it's difficult to shoot without a proper photographer. So this is the diagonal artery which is being anastomosed by the Lima. This is LAD. This is the intracoronary shunt what we used while doing CABG, so that the blood flow remain intact. This is LAD. This is the end of a Lima which is being anastomosed to LAD. So it is a sequential anastomosis from diagonal to LAD. This patient was in atrial fibrillation while operating. It was a permanent AF. This is final anastomosis. So Lima is attached to diagonal and LAD. Now this is Rima. After Y, it is anastomosed to the ramus. This is octopus or stabilizer. This will stabilize the localized area of grafting. So this is Lima diagonal LAD and this is ramus. Now Rima second anastomosis to the OM2. Here we are anastomosing OM2. after that, this is final anastomosis to the right coronary artery, PDA. You can see the flow. So along with CABG, now patients are coming with a diffuse disease where there is a lot of calcium in the arteries. So along with CABG, we do coronary endarterectomy. So these are the calcium which is present in the arteries. These are the various calciums, various arteries which have been endarterectomized. So along with CABG, we can do complete revascularization with endarterectomy. Again, patients present along with other problems along with CABGs like LV aneurysms, or patient is having a carotid artery disease, which can be dealt with at the same time. So this is the carotid endarterectomy along with CABG. So there is a significantly greater long-term survival benefit in patients with bilateral internal mammary artery grafting as compared to the single internal mammary artery. And there are various papers which are supporting the BIMA use in case instead of a single internal mammary artery. So here if you see, so initially hospital mortality rate is identical for both, for Lima and for single internal mammary artery and bilateral internal mammary. But after 12 years, if you see, there is a for BIMA patients, there is a significantly better, survival rate is significantly better than the single internal mammary artery. And there is a postoperative follow-up of 16.5 years. There is a survival rate for BIMA and SIMA for 20 years, where 50% versus 37%. Other study, it is also stating the same, that BIMA is superior than as compared to the single internal mammary artery. Same paper. Again, there is a comparison between the Lima-RIMA and a Lima-radial, where the cerebrovascular events free survival is significantly better in Lima-RIMA Y.
So can you please?
Yeah. So it is technically better, Lima-RIMA Y. Long-term preservation is better. And now what is tomorrow in case of a CABG, like MICS, where we are doing minimal invasive through a small incision instead of a midline sternotomy. So there is a robotic, as Dr. Ajay said. And there is an advancement in imaging modality, like there is availability of IVUS and OCT to see the proper coronary artery from inside. There is a CT angio which is available, MRI, FFR is available, 3D reconstruction so that we can plan better. And there is an integration of all these modalities. So what is future? This we should predict first and then prevention. Then there is a role of technology. There are various tissue engineering where the better conduits will be available in the future. There is an advancement in the medical management, patient education and engagement is important, and psychological support. So to conclude, prevention is important, early diagnosis and treatment is important, and patient should be followed up regularly in the future. Thank you.
Thank you, Doctor, for a lucid presentation. Because of the shortage of time, we will not be able to take any questions right now. The questions can be taken during the lunch hour.
Thank you, sir.
Thank you.
I request Simi ma'am to hand over token of appreciation to Dr. Kamlesh Jain, sir. So our next speaker, who actually himself is an introduction, he is the surgeon who has done first ever cardiac transplant, Dr. Anvay Mule, sir.
Dr. Anvay Mule, the introduction is very short and sweet, but I think it says it all. He's a leading heart transplant surgeon in India. He's currently the director of cardiac surgery at HN Reliance Hospital, Mumbai. Welcome.
The topic for sir's talk is heart transplant. Where do we stand?
Good afternoon, everybody. I think it is getting afternoon anyway. Thanks for the invitation by the JRH for this year's cardiology meeting. I'm told to speak on where we stand. I think in India, as far as transplant is concerned, we are running, not standing now anymore. And we are catching up very fast. As far as thank you for my introduction. As far as I am concerned, today when somebody asks me my introduction, I say I'm a courier boy. I get the heart from one person and give it to another person. The rest of the thing is done by Lord. Where is you? How you move your slides? Here, no?
And you can go ahead, sir. You can use this.
So I don't have to declare anything. I don't have any disclaimer for the heart transplants. As far as internationally where we stand is, what you see the yellow bars is for the Europe and the green bar is for the America. The number of transplant done per year. And they are amazingly increasing in America, but Europe, you can see a straight line of the yellow bars. If you look at the red bar, that is the rest of the world. That is the rest of the world. And the first time we have in 1996 the first heart transplant in India, and then from 2015 in Mumbai we had that heart transplant. I do not know what happened for so many years. There was nothing done as far as India is concerned. I think everybody was happy with valves and bypass operations. The bread and the butter, both of them. Here, if you look at the transplant, you really have to work hard. And that is why I said it's my passion. And there is nothing more than that or nothing. I will do more 4 CABGs and earn more than what I do for one transplant. And I get occupied for 2 continuous days and nights during the transplant. Look at here, this 2015 we have started. In India, the graph till to 2020, which is published data, looks like this. And it is really, we are catching up very fast. That is total till 2020 is 1,000, more than 1,000 heart transplants. And in year 2021, we were 92. That was because we are coming out of the COVID. And then 2022, 106 transplants in 1 year. So almost from few transplants in a year, now we are catching up with 100 plus transplants all over India. I'm talking about in every year. So what are the current challenges where we stand today? And the current challenges are older recipients and donors. We are getting more of them. The more heart transplant done under MCS, mechanical circulatory supports, because there are less donors, so I have to put my patients on mechanical circulatory supports. The difference in India and abroad is they put on permanent mechanical circulatory supports and send the patients home. But the cost of that is prohibitively excessive in India, which costs almost more than 1 crore for a permanent LVAD to send the patient home and then waiting for a transplant. That is another cost to him. So here we put on temporary mechanical circulatory support, and then we have got few weeks or a month of them until I get a donor. If I don't get a donor, then the mortality is 100%. So we look at these old recipients and donors first, and they are elderly, as I said nowadays. The majority of the patients are being conserved or by physicians and cardiologists, and they are put because of the RNA which has come up, and they think that RNA is the solution to that. The RNA decreases the rate of hospitalization. Remember, it does not decrease the mortality. It does not decrease the mortality. And the only way for them is a transplant. There are 4 medicines today, or maybe 5th medicine, which are given in heart failure patients. All of you know that. Beta blocker, Lasix, digoxin is now replaced by ARNI and ACE inhibitors. And then there is no 5th medicine. If the patient comes to me in heart failure, in spite of these 4 medicines, again and again, I admit them, or in ER, I give them injection of Lasix and diuretics. Temporarily they feel very good, and then they go home. And they become frequent flyer for taking one injection, maybe at the middle of the night or maybe early morning. But again, that is a temporary thing. None of these medicines decreases or increases the pumping of the heart. The main problem in a heart failure is a pump failure. And the pump, which is a muscle which is failing, none of them will improve the contractility of the heart or ejection fraction of the heart. As a cardiac surgeon, I never knew, but since the heart failure has started, I was exorbitantly looking at the 2 things. One is echocardiography, and which I had put in for option in my MCH exam, and second was immunosuppression, which I had put my option in throughout my MBBS until I started doing the cardiac transplants. Now, in these 2 areas, the cardiology, I don't look at only ejection fraction, but we look at also the LVIDD, the left ventricular internal diameter in diastole. And I think that is very important. I'm more proud of not doing a transplant in the patients who are referred to me for a transplant than what I'm happy for doing more than 160 transplants in the last 7 years or 9 years. Now, why that is important is because if I identify the patients properly, like for example, the one patient was referred to me for a heart transplant, 22-year-old man, and when I look at his blood pressure, it was 170 by 110, and his LVIDD, ejection fraction was 20%, and for which he was referred to me, and the LVIDD was 4.7, which was very normal. Unless the LVIDD is more than 4 centimeter per meter square body surface area, these patients' remodeling of the ventricle happens very easily. If it crosses that, then the remodeling of the ventricle does not cause, and then they require a heart transplant in future. Not today, but immediately in futures. And that patient who was referred for me, I waited for 3-4 hours, took the blood pressure again and again, told him to go and have a lunch. Again, he came back again. So I thought initially it's a white collar. I send him not for echocardiography, I sent him for ultrasonography, and there was adenoma of the adrenal glands, which was treated, and he was fine now. So there are certain things, but we start with an ARNI and all, and this is causing a tremendous problem. So if the patient is registered for transplant, usually we stop ARNI. Because ARNI causes severe vasodilatation, and the requirement of vasopressors in a transplant or after the transplant is phenomenal. And that against these vasoconstrictors, the new heart is not used to that, struggles a lot. And we have a lot of problems with the ARNI. So if you are giving ARNI, what decreases is the rate of hospitalization, not the mortality. Remember that. And what is going to happen in 3 years, probably will happen in 7 years. It's good for the patient. I'm not denying it. ARNI is good. I'm also giving ARNI to many patients. The delayed referrals is because of that, and for many reasons, the patients being referred at very late stage, and then they land up with a multi-organ failure. So at the moment, if I have a heart which is failing, I can deal with it. But if I got a lungs, if I got a liver, if I got a kidney, because of the heart, the other organs starts failing. And what the medical treatment does is that protect the other organs. Or MCS does is that protect the other organs. It does not increase the MCS, mechanical circulatory support, apart from the IABP in certain conditions, certain very few conditions, it does not increase the contractility of the heart. It does not protect the heart. It rests the heart and allow the other organs to do it better, so the patient becomes better optimized if he requires a heart transplant. And that is the role of the mechanical circulatory supports or the medicines. So we have to avoid them getting a multi-organ failure. And if they go into the multi-organ failure stage, probably heart transplant is not a good idea for them. And the patients who are getting now more PRA positive, panel of reactive antigen antibody positives. So panel of reactive antibodies is the one thing which, see, there are the antibodies which are produced because when we give vaccine, when I get infection, I give antibiotics, or I give blood transfusions, or because of the COVID-like thing which has happened. That is why I said the PRA is getting more positive patients I am seeing now after the COVID era than before. And in India, usually the Indians, they are less prone for PRA positivity. The white people and the Africans are more prone for PRA positive. I don't know the reasons for it, but that is what the data says. So the sensitivity in Indians, Asian population, is much less, and the chance of acceptability of the organ, whether it is liver, kidney, lung, or a heart, whatever you take, that organ is much better. What I'm talking now today of the PRA is that we have the antibodies. Antibodies do not know this is a good thing or a bad thing which has come into my body. It knows that it is not of my body, and they try to kill it, or they try to damage it, or they try to throw. Whether it's a virus, bacteria, it doesn't matter, or a parasite, it doesn't matter for them. What matters is that it is not a part of my body. And when we call autoimmune, means our own antibodies are produced against our own, so our own police system start attacking our own nationals, then we call it autoimmune disease. So we don't want PRA, and we suppress the immunity of these patients tremendously. But if the PRA is positive, then a problem comes for rejection of the heart very fast. And financial things which I don't want to speak, which is perpetual in this part of the world, and as we go on and see. So the second point we can see is more heart transplant done on mechanical circulatory support. I'm not going into the details of it, but we are the first one from India to publish the data of our temporary mechanical circulatory support insights and evolving strategies on 48 patients. We have put a mechanical circulatory support. The bottom line of this is that the patient, if I put on a mechanical circulatory support in a good time frame, if I do not, for example, on ECMO, I must get a heart in 2 weeks. Otherwise, the side effects of the ECMO starts coming back. On Centrimac, which is a temporary LVAD, I can keep the patient for 3 months on a LVAD, but hospitalized in ICU. And then the cost of that is tremendous, phenomenally high. That is why abroad, they started putting a permanent LVAD and send the patients home, and then their time comes after 2 years or 3 years or 5 years, and they do the transplants. But that is the result of that paper, and we have designed an algorithm in which patient, which mechanical support we will use, and we have published that data in a present study. Now is a combined organ and heart-lung transplants, which is we have done heart and heart-lung, we have done heart and liver, and we have done heart and kidney. They are technically more challenging, they are immunologically more challenging, but in deserved selected patients, the results are good. But still, I would not advocate, because to get the same liver, so from the same donor, to get a liver and a heart, or a kidney and a heart, and a lung and a heart is not easy. At the moment, the ZTCC, or the National Organ Transplant from Delhi, what they say is that if one organ goes to one person, then many patients will be benefited than giving 2 organs to one patient. But then that is the debate which will go on. So more sensitive candidates, which I already explained to you, and we are the first from India who have published this data, the virtual cross-match. Now virtual cross-match is already in function in USA, not much in Europe, but in USA. And every patient or recipient who is registered for a heart transplant, and every donor who has been selected for donation of the organ, their data of their antibodies and antigens is preserved in a bank. And then when the patient comes for recipient at the recipient stage, that donor will be checked against those antibodies, and then they decide whether they should go for a transplant or not. In India, it is not there, it is not possible. But the patient is presented was extremely high antibodies and was considered contraindication for a heart transplant. But once we did a virtual cross-matching, as we do for a live kidney donor transplants. Here, we don't get time. In a cadaveric donation, we do not get time to do all these things. But then we managed it somehow, and we have done it, and we do it, and we do the plasmapheresis in these patients before we transplant them and take out all the antibodies, so hyperacute rejection does not happen. The problem with the donors are getting lesser and lesser. I do not know why. Like you see the first slide of mine, which shows the international graph, the bar diagram. In America, we get almost 1,500 to 2,000 donors in a year. In Europe also, it is same 1,500 to 1,700 donors per year. In India, we do not get that. And majority. So my mortality on waiting list is more than my mortality of a heart transplant. To be very honest and simplified. So we require more donors. The donation after circulatory death is now in consideration, and no geographic constraints like from where it is coming. Then ex vivo perfusion platforms are coming up, but in India it is very, very, very difficult because the costing of it is exorbitantly high and is not possible in India. And also some medical and legal probabilities. That is, suppose I take the donor from Orissa and put them on ex vivo machine and keep it, and then after 7 days I bring it in India, and then it doesn't, nobody wants or willing to get an transplanted done, then that is lost. Who will bear the cost? There are many issues of it. I will not go into it, but we require a more equitable donation, and heart transplantation allocation policies should be changed and resolved. In some states of India, they have started teaching not only from MBBS. Now I see for MD and MS and in exams or DNB exams, now the chapter of the donation and allocation and how you identify donor and blah blah has come. In South India, in Tamil Nadu, is the first state who started giving a MBBS certificate after they have a logbook of at least 5 organ donation witness. They have done that, how you convince the patient or counsel the donor of that brain dead patients, and how to identify the brain death. That is very important. Most of the cause of death is cardiorespiratory arrest in 99.9% of the patients, and which is not true, which cannot be true. Anyway, that is long topic again and a separate chapter or a separate this thing itself, the symposium itself. The current status of the donors before COVID was much better and different. So in 2016, 17, 18, we had done almost 25 to 30 transplants, 2 per month. But now in COVID time, it has come to 1 per 3 months, and now it is coming back to 1 per month or 1.5 per month in 2024. So they are completed by more elderly donors. I'm getting more elderly donors. The donation of selected organs only. No, I don't want to donate kidney. I don't want to donate heart. I do not want to donate liver. Somehow, why? I do not know why. The difficulties of ex vivo preservation, which I mentioned, legal and financial complexities in vitro preservation, and challenges of logistics and traveling and lifting the hearts. This is our early experience, which we have published in journal for pediatric cardiac transplants, for 25 pediatric transplants from age of 3 years to the age of 18 years, and with the zero mortality. And most of them are living. The only drawback of this is after 3 years or 4 years, some of the children have stopped taking immunosuppression, and on the 5th year or so, we have seen a mortality, and then the 5-year survival of them has come to 70%, 70% since their chapter. Surgery of the heart transplant, SAMO. Nothing has changed in 15 years. In 50 years. The first transplant done in 1956, which got so famous, after that, 50 years, there is no change even in a stitch of that. Then what has changed? What has changed is awareness for organ donation. And for that, I really, really worked hard in my initial years. And secondly, what is important and what has changed is the technology. Understanding, diagnosis, management of immunosuppression, different immunosuppressions, nanotechnology, surveillance for the immunosuppression. And I'll come to that, and I'll come to that for that. So how to find out the early rejection, how to catch them very fast. So we are doing the myocardial biopsies, and the myocardial biopsy is the standard thing. For that, patient has to get admitted. It costs also a lot. Then a histopathology, and then it comes. So we have started the surveillance doing by echocardiography every month. And if there is a doubt, little bit of doubt on echocardiography, we catch them very fast and very early. And secondly, the last sentence, which is cell-free DNA and RNA. So when there is a death of a cell, the DNA of that cell and the RNA of that cell come into the blood circulation. And if it is that DNA or RNA of that cell circulating in that recipient body or blood is of a donor cell, then I know that the death of the cell has started and apoptosis has started, and so we catch them earlier. So there is not a 100% proof, but then I have to find out the sensitivity and specificity. So for last 2-3 years, we are doing this endomedical biopsy, and then presence of cell-free DNA, which has been published and known, documented, and in USA it is being done, but it is exorbitantly, again, very costly. So we, for Indian scenario, has developed a different technique of identifying this liquid biopsy, what we call. So I just take a sample of a blood of a recipient, send it to the lab, and this lab has already got a donor blood in their bank. So their DNA of that donor blood, they knew it. So if they find the same matching DNA of my recipient in my recipient blood after 1 year or 2 year, 3 year, so they can catch it very fast, and then we call the patient and confirm it by the endomyocardial biopsy. So whether to see the sensitivity and the specificity of these two things, we started doing the study and prospective study to see the sensitive biomarkers to detect the acute rejection by non-invasive technique, and it is the faster turnaround time, and so donor blood is, for that donor blood is needed. Every time we take the heart from a donor, we collect the blood also and send it to the bank to see the DNA and RNA. So novel cells, that is about DNA. What about the RNA? RNA is also very sensitive, however it is not specific. So that is the changing of the technology or the reagents what we are using to identify. That the research is being going on, and again it's a novel marker. Nowhere in the world it has been tested for RNA, which we started doing it here. And the first time we have published it in an international symposium of International Society of Heart Lung Transplants. This was published in last year. And the second thing is that cytokine storm or transplants. So we are using the cytosol. The cytosol is a filter which we use for all the heart or heart lung transplants, which absorbs the toxins. And these toxins, which causes a vasoplegic syndrome and hypotension in this post-operative period in this patient, is been less and much less. And that we have done a randomized study for the first time in the world for heart transplants patients. So this, when we published in the International Society of Heart Lung Transplant in 2023, and it has got a good acknowledgement. So the conclusion was lower perioperative inflammatory mediators because of cardiopulmonary bypass, and lot of vasoplegic things which ARNI and all which are going up. So it helps in this lowering the vasoplegia. Requirement of the MCS is less after the transplant, and requirement of surgical re-exploration was less, or brain transfusion is less. There are other problems, other things like bilirubin and all get absorbed, and many things get absorbed in this, and that is why we are using cytosol now routinely and our heart lung transplants. There is an articles and newspapers and all over the news about the xenografts and taking the heart from a pig. And we are silently working here and modifying the pigs with genetic engineering to be aligned or akin to as much as possible. And we identified 5 of them so far, and the 6th and 7th one is going on in the process. So by when it will come and what will happen, I do not know. But we in India also we are working on this project. And thank you. So where we stand today? Where we stand today as far as organ donation is concerned, for our liquid biopsies are concerned, pediatric heart transplant concerned, organ donation is concerned. And I think we are not standing, we are quite active and running around on our toes for all these things to say. Thank you very much.
Thank you very much, sir. Your volume of work speaks about you. There will be no questions, please. Do you have a paucity of time?
Yeah.
Thank you.
Sir, I asked Simi madam to hand over a token of appreciation to Dr. Anvay, sir. I request Dr. Atul Sharma, sir, to hand over a token of appreciation to both our chairpersons. Thank you.
Now we come to the end of this session. Now we are going to have a talk by Dr. Harish Mehta, who doesn't need any introduction. He is the director of the SN Raheja Cardiology Center, and attached to the Hinduja, Lilavati, HN Reliance, and he is also attached to our railway hospital. He is a proctor. I can tell you, he's a good teacher. He's a good human being, and he's going to talk on the healing heart along with the heterotrophic valve replacement, that is trick valve. So I invite Dr. Harish Mehta. He is really a pioneer of our hospital only. So Dr. Harish Mehta will speak something about the healing heart. Sir.
Thank you very much for having me here, Dr. Hafiza Sharma, and I'm told that head is also a Director General. So I'm going to take you through this only for 2 minutes. After that, I'm going to take you through something else, which probably is necessary for all of us. And I don't want the timer to go on at all. There will be no alarm. I'll finish in 30 minutes. I have 30 minutes. No, I do not want an alarm because I don't want the meditation to be disturbed. Okay, we're going to teach you meditation. We're not going to teach you anything in cardiology. I'm not here to teach you cardiology. But since we have sponsors, I have to speak about them a little bit. So I'm going to talk about heterotropic tricuspid valve replacement. So this is a treatment that we have used in a couple of our patients. So you must have seen lots of patients who have right heart failure. You have patients who come with edema feet, ascites, cirrhosis, and everybody keeps missing that because it's treated many a times as hypothyroid. Probably nobody's ever done an echo. Sometimes it is treated by a gastroenterologist as hypoalbuminemia, cirrhosis. But the moment they do an echo, they realize that they have a severe tricuspid regurgitation, severe tricuspid leak, which is called cardiac cirrhosis. So it is cardiac cirrhosis, not cirrhosis due to GI reasons or not hypothyroidism. And that's commonly missed, and it is missed in patients with mitral valve disease. It is missed in patients with primary tricuspid disease. It is also missed in patients with portal hypertension, because that's generally people don't think that portal hypertension can cause all these tricuspid regurgitation, but portal hypertension does cause tricuspid regurgitation. And the biggest miss is in patients with permanent pacemaker implantation. So many a times when you put a permanent pacemaker implantation in patients, where you put a lead through the RA and the RV, you don't realize many times you leave a significant leak when the lead goes across the tricuspid valve. So in such cases, so we had a lady from Kuwait who was labeled inoperable by doctors there and said we can't touch her because she's very high risk for this, because she also had a pacemaker and all. So we kept researching. That time this therapy was very, very raw, it was very new. And we kept researching what we can do for her, because the TriClip had not come. And the surgeons were not keen on replacing that valve for her, because as it is, her albumin was 1.8. She was morbid. She was fully bloated. Every 10 days, she needed ascitic tap. So we came across this therapy, which was there, wherein we put two valves. Can you move the next one? It's not moving. Okay. So these are two valves. You put in the SVC RA junction and IVC RA junction. So what this valve did, that's okay, I'm getting, that's fine. So what this valve does, it prevents the tricuspid regurgitation effect happening in the liver and any reflux happening into the upper body. So it started reducing edema. So it reduces edema in patients with tricuspid regurgitation. So what we effectively did, we reduced the backflow. We could not reduce her TR because we had no therapy to reduce her TR. But why did we do that? Because we knew that in case we don't do that, she's going to not last more than 3 to 6 months at the most. And if she's not going to get operated, what do we do? And what we found, theoretically, that this patient would have developed dilatation of the RA. If a tricuspid continues to leak and you will not allow the blood to go towards the liver or towards the upper body, it's going to cause RA dilatation, which effectively should lead to ballooning RA and RV failure. And the patient should die. But surprisingly, the few patients that were done abroad in the world, they did not develop that RV failure and dying. So we told her that what we are doing for you may not make you live longer than what you would have lived now, but let's give it a shot, and if you don't have issues with finances, let's give it a shot. And to our surprise, she lasted 5 years. And she died of lung cancer. She did not die of, she just died a couple of months back. She died of lung cancer. She did not die of TR or RV failure. So what it told us, so if you do it early in time, you can cause RV remodeling and allow the RV to improve the cardiac output. So you cannot do it when your RV is fully failed. As Anvay told you, if you wait for it to fully fail, then this therapy may not work. So this is about trick valve for today. So let's go to the real topic, and we can have this off. So I'm here to take you through a different journey. And what is this journey? So all of us, can anybody claim in this room that everybody is always happy? If anybody is always happy, I want the hands up. One, okay. Always happy, good, Anvay, I like it. Anybody else? Okay, so why aren't we always happy? What is the problem? What are we lacking? We are successful cardiologists, we are successful cardiac surgeons, I'm sure all of us are successful doctors, successful family members, happy family, married, everything, but yet something is missing. What is missing? What is missing? What is the problem? Because we do not realize who we really are, what is our real goal. We keep chasing materialistic goals. I'm not anti-materialistic goals. It's not bad to be rich, it's not bad to be famous. So don't misunderstand me. So it's not bad to be rich, it's not bad to be famous. But it's very important to be happy. And that is where we all lack. All, I mean, Anvay probably is already meditating, or he was born a meditator. But this is what life is all about. So I'm moving you from physical heart, which we've been talking about the whole day, to something called a spiritual heart. So do all of us agree we have a spiritual heart, or we just have a physical heart? Do we have a spiritual heart, or we just all have a physical heart? Heart pumps blood, we all know. Heart gives cardiac output, we all know. Then why do we feel pain here when we are upset? Do we feel pain anywhere else? No. Hurt is here, feeling good is here, everything is here. Why? So there has to be some connection. Why is this feeling coming only here? We keep saying that we use our brains, we are intelligent people, we can overcome everything. But yet we don't. All the feelings and emotions are in the heart. And do you know that heart is a nervous system? Do we believe that heart is a nervous system? Does heart have a nervous system? Yes? How does it work? Can anybody tell me how does it work? Autonomic nervous system. So there's something called parasympathetic, sympathetic nervous system. And there is a constant flow between the heart and the brain, supplying information back to the brain and taking it back into the heart. That we all know that. So anything that is called sympathetic drive, which we call fight and flight response, increases your heart rate. So you're running, you increase your heart rate. If suddenly you see a tiger in the jungle, you're going to run. So your heart rate goes up. And the moment you're calm, your heart rate goes down. That's the parasympathetic nervous system takes over, right? Now, you've seen Discovery Channel, all of you all? You've seen the hunt where the wildebeest is hunted by the lion or the lioness, and you see that they're running like crazy that time. The wildebeest is running like crazy because she has to save herself. And after the kill, after half an hour, you will see at the lake, both of them having water together. Both of them having water together. Lion is standing near the same lake, wildebeest next to that. Why is the wildebeest not scared that now the lioness will kill her? And why is the lioness not killing the wildebeest? Because lioness kills for hunger. Hunger satisfied, she is not interested in the wildebeest. And wildebeest senses that the lioness is full, loses the fear. So animals, fortunately, have a switch off button, right? They have a switch off button, which we claim that we are superior to animals. At times I wonder if we are, because they can switch off. So both the so-called enemies are sitting together and having water together. Here we are a human. In the morning we come out from the car and we have a problem with someone on the road where you have fought with him that he's cut your car, then that anger goes on for the whole day. You fight with your staff, you fight with your wife, you'll fight with the nurse, you'll fight with the doctor. We don't have a switch off button. Why is that? Because of that, we have a problem. Because we always want to be in control of things. We want to be in control of things. We want to be what we are, like I am the king, how can someone do this to me? So that is the biggest problem. So here I am trying to give you a recipe where you can be a king, or you are the king, but you let your heart rule the mind and not mind rule the heart. That is what heartfulness is all about. Now the biggest problem comes when we let heart rule the mind, that we get scared that people will trample over us. All people who are emotional get scared that people above, below will trample over us and they will make life miserable for us. That's why we use our mind, we don't use our heart. So whenever there's an accident, we don't go and help because we are scared कि police तकलीफ देगी, 2-3 दिन दिमाग खाएगी, I'll have to keep going to court. That's the mind. But the heart says कि please go and help, someone is in distress. We don't do that because we are scared of the consequences. But does really living with the heart make you less competitive? I don't think so. All the people who have ruled this world with a heart have been remembered longer than people who are ruled by the mind. Is Hitler as well remembered as Mahatma Gandhi? No. Why? Because Mahatma Gandhi lived with the heart. Hitler was pure brain. So heart-based people do not do badly in life. In fact, they do very well in life. It's just that the journey is slightly longer. It takes a longer time for you to peak. But to remain at the peak, the heart-based man is going to remain longer at the peak than the man who's mind-based. Because someday mind-based man will be pulled down by another mind-based man. Guaranteed. I can guarantee you that in writing. Anybody who's mind-based will be pulled down by someone else who's stronger in the mind. But a heart-based man will never get pulled down by another heart-based man or a mind-based man. So without wasting much time, I'm going to take you through meditation. So I'm going to request Dr. Mamta Sharma to give you a relaxation technique. And then for 10 minutes, we'll just close our eyes. And after that, I'll tell you why am I talking so much about heartfulness. But I'll be in time, don't worry. Shishir, we will finish on time. So this is our heartfulness, heart-based meditation, where in all you have to do is close your eyes and give a thought that there is presence of divine light in your heart, right? The moment we close our eyes, we will have millions of thoughts running into our minds, which is normal. I mean, it happens to the new meditator, it happens to the most seasoned meditator. So don't be surprised, millions of thoughts will run into your mind. The trick is, do not try to suppress the thought. Do not try to force yourself that the thought should not come to me. That is why most meditations fail, and most people say they can't meditate because they cannot sit still. That's the biggest problem most meditation faces. But the best part is to ignore the thought. Moment a thought comes into your mind, whichever thought comes, we're not going to do the kind of thought, you just remind yourself that I am meditating on the heart and I will deal with this thought after meditation is over, and drop the thought. You will end up chasing thoughts. Again, you remind yourself that you are meditating and close your eyes. That's all you have to do. Right? You got it right? Shall we begin? Yeah. So she's going to give a few commands. You just follow them. After that, I'm going to say, please start meditation. And then you will be in your heart for the time till I say, that's all. The moment I say that's all, pause for a few seconds, few minutes before you open your eyes, because it's not good to suddenly lose what you have gained. And then we'll speak after that.
Thank you, Dr. Harish. So this is a whole, yesterday and today also we were doing all the theory things we are seeing. This is just a practical demonstration of what meditation can do. And I am sure every one of you will like it. So this is just a preparation for meditation. So I'll give some commands and I'll request you to follow them. And I request the mobiles should be on silent mode, if not switched off. So sit comfortably. And close your eyes very softly and very gently. Let's begin relaxation with our toes. Wiggle your toes. Feel them relaxed. Relax your ankles and feet. Feel relaxing energy move up from the earth, up your feet, to your knees, relaxing your legs. Both your legs are now relaxed. Relax your thighs. The energy moves up from your legs to your thighs, relaxing them. Now deeply relax your bottom portion, stomach and waist. Relax your back. From the top to the bottom, the entire back is relaxed. Relax your chest and shoulders. Feel your shoulders simply melting away. Relax your upper arms. Relax each muscle in your forearms, your hands, right up to your fingertips. Relax the neck muscles. Move your awareness up to the face. Relax the jaw muscles, mouth, nose, eyes, earlobes, all the facial muscles, forehead, all the way to the top of your head. All the facial muscles are now relaxed. Now feel how your whole body is completely relaxed. Move your attention to your heart. As you rest there, gently have the idea that divine light is there in your heart and it is illuminating your heart from within and is attracting or pulling your attention inward. Feel immersed in the love and light in your heart. Remain still and quiet and slowly become absorbed in yourself.
open them once you're ready to do the same. So how did you feel? How was it? General response? Relax, good. Anybody else? Peace of mind, excellent. Anything else? So 10 minutes of meditation can do this to you. So imagine what a lifetime of meditation can do to you. Now I'm going to integrate physical and spiritual for you. Why do I talk about spiritual health in a cardiology meeting? Right? First thing, if you read the ACC-AHA guidelines, treatment of heart failure, treatment of ischemic heart disease, ancillary treatment, adjuvant treatment is meditation. Why did they do that? There has to be scientific basis. We are all science. We can't accept on face value because I am saying so it works. It works because it's scientifically proved. How is it proved? That whenever you meditate, you go into the parasympathetic zone. And parasympathetic zone does what? Slows down your heart rate, lowers your blood pressure. And that's what we keep talking to our heart failure patients. Evaporatin le lo, metoprolol le lo, right? So here is your meditation. Similarly, ischemic heart disease, we want him to be not tachycardic, we don't want his pressure high. Again works. Third, peace of mind. Peace of mind, as you said. Peace of mind again brings you to parasympathetic values. Sympathetic discharge causes increased sugars because of cortisol release. Sugar will drop. Sugar drops, blood pressure drops, heart rate drops, cholesterol drops. So spirituality helps physical health. Now one concept I want to introduce to you is, you remember that our elders, ancestors and the yogis used to live longer? And why aren't others, yogis, not living longer as now? We are all born, it's a hypothetical concept, we are all born with a bank of heart rates. God, believe in God, don't believe in God, it's up to you. God believing is not necessary, you believe in humanity. You have a fixed heart rates that you are born with. The moment you exhaust the heart rates, you are gone. Finished, you're over, right? So the yogis of olden times, they used to meditate. So the heart rate used to vary between 30, 40, 50 at the most. So your heart used to beat less. If your heart beats less, you live longer. And if you live longer and live happier, you're going to earn more. And if you're going to earn more, you're going to benefit materially also. So where is the disadvantage of integrating this into your lifestyle? I don't see any disadvantage. So that's the reason I'm here. And I'll leave you with a thought. I want you to answer this question to yourself. You don't have to answer to me because it's no point, because it's all about individual journey. It's all about your individual, what you want to do in life. The same heart question. Now there's a student who has an ambition in life that he wants to be a good engineer or a good doctor. And he realizes after his exams that his chance of getting a seat in that term is difficult. He realizes that. And he decides that he wants to wait for 6 months to see if he gets it after 6 months. and he sees the waiting list and feels कि yes 6 महीने के बाद मिल जाएगा. Then he is roaming around the counseling hall on the day of the last day of the interview. Our dean is here, ex-dean, so he knows how counseling goes. So there's always a list put up on the board on the last day of the vacant seats, right? Vacant seats का board पे लगा रहता है, whichever is vacant for that day. If it doesn't get filled by that day, they get lapsed. So on that day, the student realizes that one seat is vacant in the field he wants. He is very excited, and he feels that seat मिलने का chance ये term में ही है. And he goes to the clerk and says कि, am I eligible for this seat? So she tells him that this seat, you are second on the list. If the first on the list does not come till 5 p.m., then you are entitled to take this seat. At that time it is 1 p.m. 2 p.m., the first student approaches him, he sees him coming into the hospital or a college or whatever. Now the question to all of you is, if you were the student, will you give the seat to number 1 or not? Will you tell him that the seat is available or not? Presuming that number 1 does not know that the seat is available. He has not seen the notice board, he knows nothing. But you know that he is number 1. Will you offer the seat to him or not? That is what you all have to answer to yourself. Would you? Or would you not? How many would give it and how many would not? Okay. Not bad. So most would not give. Agreed. So this student decided not to give the seat. He also said, इसको तो पता चलेगा नहीं. I'm going to keep him entertained till 5 p.m. and I will, then he goes away, I'll take the seat. So they both go to the canteen, he talks to him, keeps entertaining him, some discussion or the other. And but अंदर कश्मकश चालू था 3 बजे तक 3:30 तक. हार्ट बोलते दे दे, माइंड बोलते मत दे, हार्ट बोलते दे दे, माइंड बोलते मत दे, हार्ट बोलते दे दे, माइंड बोलते मत दे. 3:30 को the heart gives up, the mind gives up and says कि दे देते हैं यार, I can't live like this. So he informs the student कि ये सीट खाली है भाई, तू ले ले. ठीक है? So the other fellow is excited, चलो I'll get my seat, the number 1. Now the question is, the fees has to be paid till 5 p.m. Number 1 doesn't have the money, number 2 has the money. Both of them are not friends at all. Now second thought, will you give money, will you not give money to this man? One good deed done, will you continue with the second deed? No. This is a question, this is a hypothetical situation. Not everybody would, but I just want to see show of hands, how many would now decide to give money? No, the full fees, the full fees. It's the seat of his life. It's not the seat of not his life. So might as well, some will give money, some will not give money. So let's accept that most will not give money. If I was there at that time, I would not give money. I'm being honest. And I would not even tell him the seat is available. Right? So after that, this guy says कि पैसे भी दे देते हैं यार. What's the point of living like this यार? कि ये full guilt will go on entire life कि I took his seat away. So he tells them कि तू पैसा भी ले ले मेरे को बाद में देना. So they both go inside to the clerk. And then the clerk says, yeah, we'll remove your forms and see. So this, if you remember well, I'm sure Dean sir knows this, that the rule of the university is, if you put choices of seats, if your first choice is available, you cannot take the second choice. Am I right, sir? So they remove both the forms. The form of number 2 had only one choice, the seat he wanted. He had not filled anything beyond that. So his choice was that. And the guy who was number 1 had filled 5 choices. Because he was using his brain. कि मुझे ये नहीं मिला तो ये ले लूँगा, ये नहीं मिला तो ये ले लूँगा. So his choices were number 5. So the seat which was available was the second choice of number 1. But was the first choice of number 2. It went back to number 2. So the rule of the heart takes you round, but will bring you to the destination always. Thank you very much. Anvesa doesn't agree with me.
Thank you, sir, for your nice talk. And really, Dr. Harish Mehta, for our cardiology department in Jagjivan, he's just a master of the master. We learned everything from him, starting from how to do a radial puncture to how to do the TAVR. If the cardiology department is now nationally, internationally in a level, so just all credit go to Dr. Harish Mehta. So, as a big round of applause. Now, on this recognition as a Department of Cardiology, we are doing this annual conference. We are offering a token of love to him, and not other than anybody, that is MD Madam, Dr. Mamta Sharma. I request her to hand over this recognition. Thank you.
So it is written in this plaque is token of heartful gratitude presented to Dr. Harish Mehta.
Now we are going to the next.
Good afternoon. On behalf of Scientific Committee, SAMO JRH, I, Dr. Anuja Kulkarni, now welcome you all for the second scientific session of the today's scientific program. To begin with, I would like to welcome Dr. Suparna Sen Roy, CMS Kota, and Dr. R. Kishore Kumar, CMS Nagpur, South East Central Railway, as chairperson on dais to chair the second scientific session. Thank you, sir. Thank you, ma'am. Our first speaker of second session is Dr. N.V. Bikesai. His topic is heart failure recent approach. I now request our chairperson to introduce our speaker, Dr. N.B. Bikesai. Sir, please.
Dr. Sai, I came to know him last year during our Baroda training. Excellent person. I must read this out, all this thing that is written about him. MBBS, Osmania Medical College, Hyderabad, first division with distinction in 3 subjects. MD, General Medicine, 1996, Osmania Medical College, Hyderabad. 1994 batch IRMS, joined IRHS 1996. Worked as a physician up to 2008 and developed dialysis unit in CHLGT, Lelagoda. Studied DRNB, Cardiology 2008 to 2011. 2011 passed Dr. DRNB Cardiology. Presently CSS Cardiology, CH Lelagoda. Received GM Award and CMD Award. Presented scientific papers in RAPICON, APICON and IAE. Training DNB Medicine PGS from 2007. Dr. Sai, I'm glad to be introducing you. The stage is yours now.
Thank you, Dr. Suparna. Respected chairpersons, respected DGRHS madam, all the PCMDs present here, CMSs, senior cardiologists, cardiac surgeons, ladies, doctors, ladies and gentlemen. So after a nice meditation session, I really forgot that I have to give a talk now. And then today's talk, I thank Dr. Shishir for giving me this privilege and opportunity to present heart failure recent approach. So we all traditionally know that the heart failure is classified as left heart failure, right heart failure, so forward heart failure, backward heart failure, congestive heart failure and all. So basically, literally, heart failure is said to be present when there is inability of the heart to pump blood sufficient enough to meet the metabolic needs. So today I'll be discussing about the heart failure, but heart failure is such a big topic that it takes nearly 4 hours to discuss about heart failure. So what I'll be doing in the coming 15 minutes is giving a bird's eye view of the heart failure with focus on the preventive aspects in stage A heart failure that will lead to reduction in morbidity and mortality and lead to the overall cost effectiveness of the treatment. Slideshow. So now the recent, I'll be going through the American Heart Association and European Society of Cardiology guidelines, and the recent guidelines are to classify heart failure as heart failure with reduced ejection fraction, heart failure with mid-range ejection fraction, and heart failure with preserved ejection fraction. So the symptoms, coming to the symptoms of heart failure, basically the symptoms of heart failure are, we all know, are dyspnea and dyspnea on exertion. The symptoms of left heart failure include paroxysmal nocturnal dyspnea, orthopnea. The signs of left heart failure include LV, S3, gallop sound. The signs of the right heart failure or congestive heart failure include raised JVP, hepatomegaly, and pedal edema. All these we have been taught since our childhood. And then the heart failure with reduced ejection fraction is classified as symptoms and signs with an LV ejection fraction less than or equal to 40%. Coming to the heart failure with mid-range ejection fraction, we have symptoms and signs with LV ejection fraction between 41 and 49%. And coming to the heart failure with preserved ejection fraction, we have found that those individuals who have good LV function or good LV systolic function greater than 50% do have symptoms and signs of heart failure, symptoms of dyspnea on exertion or dyspnea, and also the signs of left heart failure. And there's an objective evidence of cardiac structural or functional abnormalities. Here the basic abnormality is LV diastolic dysfunction. So there is a left ventricular diastolic dysfunction. There is an impairment in the relaxation of the left ventricle leading to raised left ventricular filling pressures, that is the left ventricular end diastolic pressure. Because of the fibrosis, there's impaired left ventricular relaxation leading to this concept of diastolic heart failure or heart failure with preserved ejection fraction. And this includes raised BNP levels also. So coming to the epidemiology and causes, between 2009 to 2014, we had seen heart failure related deaths have increased, whereas in 2013 to the 2017 era, the heart failure hospitalizations have increased. And between 2011 to 2014, the heart failure with reduced ejection fraction declines, but there's an increase in heart failure with preserved ejection fraction. Probably the decrease in heart failure with reduced ejection fraction is because of improvements in myocardial infarction management, institution of the golden hour treatment by thrombolysis or by primary angioplasty. So coming to the causes of heart failure, the risk factors for heart failure are very important. Hypertension, obesity, prediabetes, diabetes, and atherosclerotic cardiovascular disease form the risk factors for heart failure. And ischemic heart disease and myocardial infarction constitute good significant causes of heart failure, especially those myocardial infarctions who have presented late or wherein the treatment could not be instituted in golden hour. These myocardial infarctions, especially the interval myocardial infarctions, they end up with residual left ventricular dysfunction leading to left ventricular failure and reduced left ventricular ejection fraction. Coming to the non-ischemic causes, we have the chemotherapy like cancer-related drugs like anthracyclines, VEGF inhibitors, cardiotoxic medications, rheumatological conditions, autoimmune disorders like sarcoidosis, eosinophilic myocarditis, endocrine disorders like thyrotoxicosis, metabolic disorders like diabetes producing cardiomyopathy. Then we have another class called familial inherited or genetic heart disease, heart rhythm related like tachycardia mediated cardiomyopathy, PVC-mediated cardiomyopathy, and right ventricular prolonged pacing also can result in cardiomyopathy. Untreated hypotension produces cardiomyopathy. Amyloid, sarcoid, hemochromatosis are important infiltrative disorders. Myocarditis, peripartum cardiomyopathy, Takotsubo or stress cardiomyopathy, and substance abuse, alcohol, cocaine, all are important causes. So basically, we evaluate the symptom signs. ECG is fundamental. And hormone biomarker assessment by NT-proBNP, that is brain natriuretic peptide, and echocardiogram. So now the diagnostic algorithm as proposed by the European Society of Cardiology is in all suspected heart failure, we evaluate the risk factors, symptoms and signs and the ECG. If the ECG is abnormal, we perform the NT-proBNP or BNP in all cases, and if it is high, more than 135 picogram for NT-proBNP and more than 35 picogram per ml for BNP, then we go for echocardiography and there are abnormal findings. Its heart failure is confirmed and classified according to ejection fraction and then treated accordingly. If the NT-proBNP is normal and the echocardiography is normal, then heart failure is unlikely and we have to consider the other diagnosis. So chest X-ray is a class 1 recommendation as per all the guidelines. Chest X-ray in heart failure cases to detect cardiomegaly and the pulmonary congestion. The echocardiography to be done in all cases wherein the left ventricular size, the diameters, the internal diameter, the systolic diameter of the left ventricle, diastolic diameter, calculation of the ejection fraction, assessment of mitral regurgitation are all important components. So transthoracic echocardiography is a class 1 recommendation. Cardiac CT, CMR, and SPECT, these are specialized investigations done as a class 1 recommendation when the evaluation by TTE becomes difficult due to poor echo window, wherein the ejection fraction calculation becomes difficult. In such cases, cardiac CT MRI is recommended as a class 1 indication. And when there is a significant clinical change or who have received guideline-derived medical treatment and are being considered for invasive procedures or device therapy, accurate assessment of ejection fraction can be made by cardiac CT or cardiac magnetic resonance. Ischemia evaluation forms an important component of heart failure. Even though the recommendation given is class 2A, still we feel that ischemia evaluation is very important because it is one of the, by identifying of ischemia by coronary angiogram and treating the ischemia by revascularization, many of the patients do improve from their heart failure. So when there is class 3, wherein the given procedure is of no benefit, it is with patients with heart failure in the absence of any clinical status change. So coming to the staging of heart failure, the universal definition and classification of the heart failure, stage A is patients at risk of heart failure, like those who have no current or prior signs or symptoms of heart failure, no structural biomarker or genetic markers for heart disease, and these are the patients with diabetes, hypertension, and obesity. Stage A is very important in preventive cardiology, and the theme of this conference is from intervention to prevention. So it is at this stage A that we intervene and treat the conditions of diabetes, hypertension, pre-diabetes, or obesity. Definitely the progression to further stages of heart failure is delayed or prevented. And stage B heart failure is a pre-heart failure, wherein there are no current or prior signs and symptoms of heart failure, but there is a presence of structural heart disease, functional cardiac abnormality, or raise in cardiac biomarkers like NT-proBNP, BNP, or highly sensitive cardiac troponin. Stage C heart failure is that patients with current or prior signs and symptoms of heart failure and those with cardiac structural or functional abnormality. And stage D is those with advanced heart failure and who are having recurrent hospitalizations in spite and despite of guideline-derived medical therapy. And these are the patients who require advanced therapies like heart transplant. So the assessment of the patients is very important with BNP and transthoracic echocardiography, and we confirm the heart failure diagnosis. We initially classify them into heart failure with reduced ejection fraction, mid-range ejection fraction, and heart failure with preserved ejection fraction. And once we start the treatment, this is not enough. And serial assessment and reclassification is important because many a times we find that patients with heart failure with reduced ejection fraction who are on ARNI, the newer drugs with sacubitril and valsartan, and complete guideline-derived medical management, they do improve their ejection fraction, and subsequently they have to be classified into either mid-range or improved ejection fraction. So coming to the treatment of heart failure, the treatment of heart failure is broadly by the guideline-derived medical management, and the AC inhibitors and angiotensin receptor and neprilysin inhibitors, ARNI, that is the sacubitril valsartan, beta blockers, mineralocorticoid receptors, empagliflozin and dapagliflozin, that are the SGLT2 inhibitors, and loop diuretics. These are the 4 pillars forming the class 1 indication for treatment of heart failure with reduced ejection fraction. And then for those patients with left ventricular ejection fraction less than 35% and QRS duration less than 130 milliseconds, and where appropriate, ICD is to be considered. That is cardiac implantable, automatic implantable cardioverter defibrillator. So in ischemic cases, class 1 indication is given, and in non-ischemic, class 2 indication is given. And those individuals with heart failure with reduced ejection fraction who are in sinus rhythm and LV ejection fraction less than 35% and QRS greater than 130 milliseconds, we have to consider cardiac resynchronization therapy, which is either CRT-D or P, and those individuals wherein the LVBB is there and QRS is more than 150 milliseconds, it forms a class 1 indication. If the LV ejection fraction is more than 35% and device therapy is not indicated or inappropriate, and if the symptoms still persist, in spite of all the 4 class 1 recommended drugs, we go on to the class 2 recommended drugs. So coming to the guideline-derived medical management, heart failure with reduced ejection fraction, the step 1 is to optimize with the 4 pillars of this. There are the ARNI or AC inhibitors, beta blockers, mineralocorticoid receptor antagonists, and SGLT2 inhibitors and diuretics in appropriate doses and complete full dosages. And then the step 2 is to see how the patients are responding. And step 3 is in individual cases like African Americans, hydralazine and nitrates as per the VHEFT trial are useful. And in those individuals who have, as already told, we have to identify those requiring AICD or CRT-D. And then in cases of selected patients who are not responding to the guideline-derived medical therapy, the consideration, and also do not respond to, they are non-responders for CRT, and wherein all the measures have failed, there is a progression in heart failure, there is a stage D heart failure, then and if there are no contraindications for heart transplant, the cardiac transplantation can be considered. So coming to the additional medical therapies after optimizing guideline-derived medical therapy are ivabradine. Ivabradine is a funny current inhibitor, and this drug is a class 2 indication. That means there's a moderate amount of evidence to say that it is it's of benefit. So in patients with left ventricular ejection fraction less than 35%, heart rate greater than 70 per minute, we give ivabradine as an add-on therapy. Initial dose is 5 milligram BD and target dose is 7.5 BD. Vericiguat has come off late, which is a guanylyl cyclase stimulator with the initial dose of 2.5 mg OD to a target dose of 10 mg OD. So these drugs, digoxin has now, in our MBBS days, heart failure management means digoxin and diuretics, but now digoxin has taken a back seat and it forms a class 2B in the indication. And PUFA, that is polyunsaturated fatty acids, and potassium binders in case of hyperkalemias or the other drugs. So basically, in heart failure with reduced ejection fraction, with the paradigm heart failure major trial, landmark trial, the ARNI or the sacubitril valsartan group of drugs have come to the mainstay, but they are contraindicated in patients with renal failure. So serial assessment of potassium, sodium, urea, and creatinine have to be done. So coming to the presence, if there is a treatment approach in secondary mitral regurgitation, if there is ischemia, documented ischemia along with secondary mitral regurgitation, if there's a documented ischemia along with the secondary mitral regurgitation, we go ahead along with the CABG, we also do the mitral valve surgery, which forms a class 2A recommendation. And if there is a severe mitral regurgitation, like with all the things like left ventricular ejection fraction greater than 50%, mitral valve surgery forms a 2B indication. Whereas with left ventricular ejection fraction below 50%, if the mitral valve anatomy is favorable, there's a role for transcatheter edge-to-edge mitral valve repair, which has a class 2A indication. And in the presence of unfavorable mitral valve anatomy, so mitral valve surgery, mitral valve repair again has a 2B indication. So coming to the recommendations for patients with mildly reduced ejection fraction. Here also diuretics are class 1, they are very important, stay. And next line of drugs are SGLT2 inhibitors, dapagliflozin, empagliflozin, AC inhibitors, ARBs, ARNI, MRA, that is aldactone, spironolactone, and there's also evidence-based beta blockers for heart failure with reduced ejection fraction. So in patients with heart failure with improved ejection fraction, so with all these drugs, we find that many cases, in serial follow-up, the heart failure with improved ejection fraction has occurred, and the recommendations are here that class 1 recommendation is that in patients with improved ejection fraction after treatment, guideline-derived medical therapy should be continued to prevent relapses of heart failure and LV dysfunction, even in patients who may become asymptomatic. So coming to the criteria for definition of advanced heart failure, all these criteria are there wherein there's a severe cardiac dysfunction, and it's not, and there are episodes of pulmonary or systemic congestion and arrhythmias, and patient's exercise capacity is less. We call it an advanced heart failure. So we have this meta-analysis of SITS trial where fluid restriction is said to be of benefit or not benefit. There's a controversy, but my personal opinion is fluid restriction is very important aspect in management, medical management of heart failure. And this is the algorithm for advanced patients with heart failure, wherein the role of these left ventricular assist devices is there. They are basically bridge to recovery, bridge to transplant and all. Basically, LV assist device is very costly, about 1 crore is the cost of it. And it is basically used for advanced heart failure patient as a bridge to transplant. And then there are various indications and contraindications for this, and they have already dealt with by the previous speaker. Cardiac transplant has been extensively dealt with by the previous speaker, and hence I'm not going into details. And this is for selected patients, class 1 recommendations with advanced heart failure, with failure of guideline-derived medical management, and cardiac transplant is indicated to improve quality of survival. So now coming to the worsening heart failure, yesterday there was a big talk, and all the precipitating factors of heart failure should be identified, like acute coronary syndrome, hypertension, atrial fibrillation, infection, sepsis, non-adherence to treatment, thyroid function, anemia, and any sodium retention, and all these things should be considered pulmonary embolism, and they should be corrected. So now IV loop diuretics are important, and we give them, and if they are not responding, we increase the dose of loop diuretics or give continuous infusion to decongest the patient. And apart from these, beta blockers, mineralocorticoid receptor antagonists, and ARNI or ACE inhibitors are very important in the management. So comorbidity management is also important in heart failure. Management of anemia with iron deficiency. Yesterday there was a talk on this, and we have to correct the anemia by ferric carboxymaltose, wherein there's a significant improvement in heart failure symptoms. So management of sleep disorders also is very important. Patients usually have obstructive sleep apnea syndrome, so we have to address this issue also by CPAP. And management of hypertension is also very important. Management of diabetes by SGLT2 inhibitors is important. Drugs not to be given in heart failure are pioglitazone group of drugs, that is thiazidinediones. So cardio-oncology, here we have to identify if there is any patient who have developed anthracycline-related cardiomyopathy. We have to discuss with the oncologist and plan the treatment strategy, whether to stop that drug temporarily or so. And pregnancy and heart failure is also an important area in heart failure management, especially those cases with peripartum cardiomyopathy, wherein in subsequent pregnancy, counseling has to be done regarding contraception, and the risks of cardiovascular deterioration during pregnancy should be provided. And in women, class 3 is not indicated or contraindicated. ACE inhibitors, ARBs, angiotensin receptor blockers, ARNIs, sacubitril valsartan, ivabradine, SGLT2 inhibitors, and vericiguat. Almost, unfortunately, all the drugs are having significant risk of fetal harm. So now coming to preventive cardiology, which is very last slide, just a minute. So coming to preventive cardiology, which is a very important aspect in heart failure, especially in relation to our conference theme. These are the at risk for heart failure patients. Primary prevention is very important. And patients with hypertension optimally select the drugs and optimally reduce the blood pressure, and diabetes to be treated optimally, and with all which HbA1c be maintained below 6.5. Cardiovascular disease should be addressed. Patients with exposure to cardiotoxic agents should be identified. And what is important is patients with first-degree relatives of patients with genetic or inherited cardiomyopathies. They have to be identified, and genetic counseling and screening should be provided. And patients with at risk of heart failure, they should be given BNP screening and monitoring of BNP. And patients with at risk of heart failure, should be validated multivariable risk score, and according that we have to manage lifestyle management strategies. So preventing this syndrome is important, and with in overall concept, and Indian Railways with its extensive network and with its HIMS in place, we can do a lot in prevention and progression from stage A, stage B to stage C and stage D heart failure, which is the theme of this conference. With this, I thank you all for the patient listening.
Thank you, sir. In view of paucity of time, we request audience and chairpersons that we'll have a question and answer session in the lunch break. I would now request Dr. Suparna Sen ma'am to hand over a token of honor, a memento, to Dr. NVB Kesai.
So one question I would like Dr. Shishir also to address is in heart failure with reduced ejection fraction in our medical examination patients, we give them C1 and below or sedentary duties. What will we do with heart failure with preserved ejection fraction? It's one which we can discuss.
Usually, if we have taken care of all artery, if we find out there is no reversible cause of heart failure and is a EF, then and your effort is good, then we usually make fit in the same category. Sir. Thank you. Kindly, we are inviting, due to some mutual exchange, we are taking Dr. Rajiv Kohli, who is going to have cardiovascular complication of diabetes. So we have not touched the diabetes so far. So he is going to have, and I request sir to stick to the time because we are running out the short of the time. Please go ahead, sir.
Thank you so much, Dr. Rahul. Thank you, the entire organizing committee, for this conference, for inviting me here. So I'm a little different from all the presenters who are presented today. I'm going to speak about diabetes and its impact, and I'm sure the learned audience here knows a lot about. I'm just going to reiterate all the things that you are aware about and how probably we could work together to prevent the cardiovascular complications in diabetes. So around, we have 100 crore people with diabetes and around 126 million pre-diabetes and 100 million diabetes in India. And 60 to 70% of them are going to die of cardiovascular disease. So that's where our problem lies, and the solution lies in events like this. And if all of us, as my previous speaker was alluding to, could do a guideline-directed management, half of our cardiologists would be out of work. So what is diabetes? Diabetes is a vascular problem. We identify with it being just a blood sugar, and we look at parameters like HbA1c, but we know that the metabolic issues in diabetes drives not only cardiovascular disease, but also chronic kidney disease globally. And when I say this, and when we look at data, especially rising out of India, we do not come across people who are just the garden variety people with just hyperglycemia. We have patients, majority of our patients have more than one risk factors. So whether it is hypertension, which is seen in almost 60%, dyslipidemia 75%, chronic kidney disease between 35 to 40%, peripheral neuropathy in a very high percentage, 25% with diabetic retinopathy, obesity, which is close to 355 million people in India, is almost 60 to 70% of our patients are obese. So we are looking at majority of our patients with risk factors. So it's a simple patient with hyperglycemia only is not there. And the goal of the national health policy is to ensure that we are able to reduce 25% of premature deaths by 2025 in India. And that seems to be a goal that we are very far from it, because we are not able to take care of the risk factors as such. And the risk factors are all these that we know. And that's why we have premature diabetes and premature heart disease. We have, at every BMI, we have high adiposity. And importantly, diabetes is not where the chicken and egg about insulin resistance and insulin sensitivity comes in. it is the ectopic deposition of fat in various organs and how that ectopic deposition of fat reduces the function of each and every organ. So whether it's the liver, we identify it as MASLD or NAFLD or MAFLD. We have the diabetic kidney disease. We have fat in our pancreas. So there's a lot of crosstalk between these organs and a metabolic crosstalk, and one organ actually deteriorates the function of another organ. So the thin fat Indian phenotype is seen if you compare it to Caucasians and especially people from the UK. We'll see that we are at a lesser BMI, but we have more adiposity. Our age of diagnosis is at least a decade higher. And this is seen also in our ICMR INDIBE study, which came into publication last year, which is one of the best epidemiological data as far as diabetes goes. And if you see that the arrow goes upwards by the age of 25 to 30. And earlier, as we used to say that we need to be at least 40 to actually screen for hyperglycemia, the days are over, because the arrow starting going up at 25, and post-pandemic you can see a lot of these things changing as such. And when I talk about diabetes, it's also essential to understand that what we actually treat today are numbers, and whether these numbers have values, because the numbers are finally an effect of an underlying problem. And probably the problem has been there much, much earlier than the numbers indicate today. So we are treating HbA1c, we are treating blood sugars, we are treating LDL cholesterol, we are treating blood pressure, we are treating weight, but we are not treating the cause. And that's where the problem lies, that probably the cause is much, much earlier, and probably the insulin resistance, which seems to be the unifying common soil hypothesis for these problems. You may have some patient with insulin resistance developing NAFLD and progressing to NASH cirrhosis and cardiovascular disease, and somebody who develops diabetes and then develops chronic kidney disease. But the core problem continues to remain the same, and you end up seeing a lot of subclinical atherosclerosis also in patients with prediabetes. So the cause and effect is here, that you may have subclinical atherosclerosis in mild hyperglycemia also, and it starts much, much earlier before the onset of diabetes. So Nurses' Health Studies, a long prospective study for 35 years, where they followed up nurses for more than 35 years, and as you can see, the risk of MI or stroke as compared to their years of diagnosis. So when they get closer to the diagnosis of diabetes, the risk of MI and stroke also goes up. You may say that it's probably the age, but if you compare it to age-matched people without diabetes in the same study, you will see that as you get closer to the onset or to where your diagnosis comes in, the MI and stroke or cardiovascular impact goes up. And if you look at one of the most seminal papers or seminal studies in diabetes, which is the UKPDS, which is a very sincere study, was done in patients who were newly diagnosed and at a mean age of 53. But almost close to 20% of them had retinopathy. So many of our patients who come to us and say that I have just been diagnosed in 2024, if you actually screen for their microvascular or macrovascular complications, you may find complications in 15 to 20% of them. And there's a retinal epidemiologist by the name of Robert Klein who did a sub-analysis of this after this paper, and he said that you need at least 6 years of hyperglycemia for a person to develop diabetic retinopathy changes. So almost 20% of people in the UKPDS study, which was done in newly diagnosed people, may have had diabetes for at least 6 years. So many of our patients whom we say are newly diagnosed may not be newly diagnosed, they have found out then, but if you actually screen for their microvascular complications, you may get a nephropathy or a neuropathy or retinopathy in a large majority of them. And one of the real world data which we had also participated in tells us that retinal and kidney related issues are very high and vascular complications at the time of diagnosis. This is real world and not an RCT, but this kind of study tells us that our patients are not asymptomatic or without risk factor. This is a very good paper from a friend called Samit Gosal from Calcutta. What he did is that he looked at the Q-risk score and then extrapolated it to our patients. And we all know when the Q-risk score is more than 20, the patient is at higher risk factor for a cardiovascular event in the next 10 years. And by the age of 35 to 40, you can see that the Q-risk score in Indians is going up. But there's a gender difference. You know, between 45 to 50, males are having a higher Q-risk score, which means that probably they have a higher risk for a cardiovascular event in the next 10 years. But as it goes higher, the gender difference goes off. So postmenopausal women carries the same risk factor that a man carries by the time he's around 50 years. So if you see 65, 75, and 55 to 64, it's almost getting flattened. Again, data from where they extrapolated it to almost 4,000 patients and realized that this is what is happening in India. Again, a lot of these subclinical cardiac disease start increasing from pre-diabetes itself. We had a previous speaker who spoke about heart failure and how stages of diabetic cardiomyopathy comes in, whether we earlier used to call it as diastolic dysfunction, backward failure, so many things. But you have a lot of things which occurs with hyperglycemia, whether it's myocardial fibrosis, whether it's change in the free fatty acid of the myocardium, which actually makes a functional change in the myocardium, and you land up with some kind of heart failure. And nearly 1 out of 2 people with type 2 diabetes have diastolic dysfunction, and many of them may progress towards heart failure with preserved ejection fraction. And if you look at another paper from another friend from Pune, which looks at cardiovascular risk in newly diagnosed patients, it's very, very high, to the tune of almost 39.5 to 40% of a patient. This data almost a decade back, which actually looked at Indians versus Caucasians in the UK and looked at their asymptomatic coronary artery disease with the help of a CT core angio, said that in 2 out of 5 people from the South Asian community have a higher significant coronary artery disease as compared to age-matched Caucasians, and this seems to be the same risk factor profile. Just going on to further what cardiovascular disease you can get, obviously you can get acute metabolic issues like neuroglycopenia, you can get hyperglycemia and causing a non-ketotic state, you can have advanced aging, vascular we know we can cause stroke, microangiopathy, consequences could be dementia, hearing loss, which is very common in India. None of the glucose lowering drugs have actually helped in cognitive function except GLP-1s and DPP-4. GLP-1 has a lot of data coming up in Alzheimer's and multi-infarct dementia, and today Alzheimer's is also called as type 3 diabetes because insulin resistance seems to be the cause. Chronic kidney disease is also a complication that we need to deal with because majority of our patients who have chronic kidney disease actually do not progress towards dialysis. This is also a sub-analysis from the UKPDS that patients who have chronic kidney disease, 7 out of 10 die of a cardiovascular event rather than progress towards dialysis. So all these patients, the guideline-directed management needs to be very much there, and we need to stage our patients based on eGFR as well as albuminuria so that we know what is the risk factor for each of them, and we can repeat the annual or the biannual measurements to actually risk classify them. Again, data from India that more than 50% people with diabetes attending medical clinics have diabetes, hypertension, kidney disease as such. And we all, this is old data which again suggests that it can actually have more major cardiovascular events as compared to progression to diabetic kidney disease and end-stage renal disease. Diabetic retinopathy, cardiovascular autonomic neuropathy, very difficult to diagnose, but nearly 1 out of 5 people have some form of cardiovascular autonomic neuropathy in people with diabetes. So what is the prevalence of cardiovascular disease? 1 in 13 have stroke, 1 in 10 have MI, 1 in 7 have heart failure, 1 in 5 have coronary artery disease. So 1 in 3 have some kind of cardiovascular disease. 1 in 5 have cardiac autonomic neuropathy. 1 in 4 have NAFLD with liver fibrosis, which is advanced liver disease. 2 in 5 have chronic kidney disease. 1 in 2 have LV diastolic dysfunction. 2 in 3 have obstructive sleep apnea. So we don't see the garden variety of people. We have people with these problems, and whether we look at the heart and atherosclerosis or we look at a microvascular complications like chronic kidney disease and ACR, there are lot of times that we can intervene, prevent the retardation of all these problems, and guideline directed management needs to be there. Just getting into one benefit of a data which, so that I can conclude, is that adherence is extremely important. Follow-up is very poor of our patients, 35% patients follow-up. Adherence is just close to 40 to 45% of the medications which we give. This is a data which suggested that a multifaceted intervention where you have the clinician who's doing visits, monthly activated site calls from the physician clinic, patient has given a medicine passport and a fact sheet, and the system is giving them calls, reminders, whether they are adherent. And what they were looking at was just SGLT2, statin, which is one of the foundations of preventive cardiology, and a RAS inhibitor. And whether these 3 drugs could be adherent to patients with diabetes who have cardiovascular disease. So if we can have an approach where we are able to convince the patient, the caregiver and our system, the adherence will improve, and if we can have at least 70% adherence, at least we can have 25 to 30% reduction in cardiovascular disease. So I would summarize that Indian people are at very high risk for complications. It's premature. Beyond control of glycemia, we need to have a holistic approach, and evidence-based therapy need to have optimum patient education which can improve adoption and adherence and outcomes for holistic care. Thank you so much for the pressure.
Thank you, Dr. Kovil.
Thank you, sir. I now request Dr. R. Kishore Kumar, sir, to present a memento to Dr. Rajiv Kovil. Thank you, sir. Our next speaker is Dr. Ruchit Shah. His topic is cardiologist versus cardiac surgeon, whose baby it is. I now request our chairperson to introduce Dr. Ruchit Shah.
Dr. Ruchit Shah is structural and interventional cardiologist who deals with valves like TAVR and MetroClip from LA, USA. She is the organizer, Epicon, organizer India Live, faculty at national and international conferences, and publications in various national and international peer-reviewed journals. She is ex-JRH and BAMH at SciFi, Justlock, Bridge Candy, Ocards, and Messina. Dr. Ruchit, please come.
It's a request everybody has to deposit the feedback form to get the proper MMC point. So we are distributing the feedback form. Kindly submit before you leave the hall.
In view of paucity of time, we will have question answer session during the lunch. I request all speakers to please stick to the time, and bell will ring at 15 minutes and 20 minutes interval, and 8 minutes for 10-minute talk. Thank you.
Thank you so much for having me here. Thank you, Dr. Shishir. I remember my days in 2006 to 2009. I was a student here, and it's indeed an honor to be present here and present in front of this elite audience. So the idea of this talk is to empower you to understand how cardiologists and cardiac surgeons decide when a patient should undergo an angioplasty or a CABG. The traditional teaching is that yes, triple vessel disease, go ahead for a bypass surgery. Single vessel disease, go ahead for an angioplasty. I beg to differ. There are multiple factors which need to be considered before we decide whether the patient should undergo medical management, angioplasty, or bypass surgery. The debate began well in 1979 when Andreas Grunzing first discovered the art of angioplasty. Since then, they have been discussing and dissecting whether to do angioplasty or bypass surgery for a needy patient. There's always been a confusion whether to revascularize or not to revascularize. With this, I'll be showing you a few cases, and then we would be discussing certain points on how do we decide about angioplasty versus bypass surgery. So this is a 67-year-old gentleman, known hypertensive, uncontrolled diabetic, complaining of exertional breathlessness, chest discomfort, ECG echo normal, treadmill test positive for inducible ischemia, BP 180 by 100 millimeters of mercury, troponins negative, sugars absolutely uncontrolled, HbA1c 10.1. And there's dyslipidemia. This is the angiogram. The first figure to the left is showing a left circumflex diffusely diseased. The second figure is showing a left anterior descending artery diffusely diseased. And the third is showing right coronary artery, which is having distal disease. May I point? Yeah. Yeah, so this is the left circumflex artery, which is diffusely diseased. This is a left anterior descending artery, which is diffusely diseased. And this is the right coronary artery. Now this patient, what should be the plan of action? We did a stress myocardial perfusion imaging. There was no inducible ischemia. Hence, this patient was treated with aggressive medical management, good control of blood pressure, good control of sugars, dual antiplatelets for some time, followed by single antiplatelet, high dose statin, and did well for 7 or 8 years with aggressive medical management. That patient expired in COVID. This is another patient, 55-year-old female, hypertensive, non-diabetic, complaining of exertional angina, STD changes in inferior lead, ejection fraction is 55%. The first figure is showing a lesion in the right coronary artery. The next figure is showing a lesion here in the left anterior descending and the left circumflex artery. So herein we see that the patient is also having some diffuse disease in the distal left main coronary artery. Well, all over the guidelines are that if there is left main coronary artery involvement, you prefer a CABG. However, we did an intravascular ultrasound for the left main and we found it is not significant, it does not need to be touched. This patient was treated with multi-vessel angioplasty. Here's the next patient, 50-year-old male, uncontrolled diabetic, obese, obstructive sleep apnea syndrome, COPD, complaining of exertional breathlessness, ECG, T inversion in inferior leads and flattening in V2 to V3, ejection fraction of 40%. So herein we have the left circumflex, which is diseased, and the right coronary artery, which is diseased. Now this patient, all the lesions are amenable to angioplasty. Moreover, this patient had multiple comorbidities, hence this patient underwent multivessel angioplasty. Next patient, 68-year-old gentleman, hypertensive, diabetic, smoker, recurrent heart failure, old coronary artery disease, triple vessel disease, on medical management, ECG Q waves in V1 to V6, ejection fraction 25%. So herein we see, so herein we see that this patient is having a severe right coronary artery disease. The left coronary artery is totally occluded and the LAD is filling retrogradely via collaterals from the right coronary artery. This patient was treated with CABG and this patient is doing well. Another patient, 56-year-old gentleman, hypertensive, tobacco chewer, complaining of classical angina, ejection fraction 45%. So this patient has lesion in the left anterior descending artery, the ramus, and the right coronary artery. We had given the patient option of CABG versus multivessel PCI. It was the patient's choice to go ahead for a CABG. So what are the factors that we consider while deciding CABG versus multivessel PCI? The previous few cases, we had patients across all spectrum having multivessel coronary artery disease. One patient underwent medical management, 1 or 2 patients underwent CABG, 1 or 2 patients underwent multivessel angioplasty. So the factors which we use for selection are patient symptoms, lesion severity, lesion eccentricity, calcification, tortuosity, unprotected left main disease, multivessel disease, proximal LAD disease, bifurcation, chronic total occlusion, whether the patient is having serial lesions, if those lesions are functionally significant or no, the vessel size, the graftable size, are we in a position to achieve complete revascularization? Do we need hybrid revascularization? Should the patient undergo medical management, etc.? Most important is patient choice, patient preference. We also look into whether there is renal insufficiency, peripheral vascular disease, liver failure, pulmonary disease, inability to take dual antiplatelets, obesity, old age, socio-economic status of the patient, and aim for complete revascularization. We also look at other parameters on echo and myocardial perfusion imaging, such as systolic wall thickness, diastolic wall thickness, regional wall motion abnormality, myocardial metabolism on a myocardial perfusion imaging, and decide. So having known that there are so many factors that need to be considered before we plan a patient for an angioplasty or a bypass surgery, we must visit some important data. Well, bypass surgery was discovered more than 4 or 5 decades back. At that time, angioplasty was in its infancy. The results of that time, when bypass surgery was at its peak and it was only plain old balloon angioplasty, bypass was far superior to angioplasty. But then we realized that venous grafts, 1/3 would be occluded pre-discharge. So there were guidelines placed as to arterial revascularization is important. So then came the era of total arterial revascularization. Meanwhile, angioplasty progressed from old balloon angioplasty to bare metal stents, followed by first generation drug-eluting stents, second generation drug-eluting stents, and now the latest drug-eluting stents. Subsequently, the strut thickness or the strut thinness of the drug-eluting stents has reduced from more than 113 microns to 65 microns. It has reduced. With this, there is definitely a reduction in stent thrombosis, in stent restenosis, and repeat revascularization. So this is old data, 3 decades back, when bypass versus bare metal stents. So herein we see all trials show that bypass was superior to angioplasty, but that is 3 decades back. And then 15 years back, there was the syntax scoring system, which has multiple parameters. It is freely available online. We can enter the patient age, gender, and all the anatomical factors and achieve a syntax score. So if the syntax score is beyond a particular number, as shown here, in that case, bypass surgery is superior to angioplasty. However, if syntax score is low or intermediate group, the patient can be offered angioplasty versus bypass surgery. Well, syntax score has now had a follow-up of 13 to 14 years. Meanwhile, we had a concept of functional syntax score. The first syntax score was the anatomical syntax score, and now there's a concept of functional syntax score. I'll come to it later. So the syntax score study, it said patients with low risk syntax score or intermediate risk syntax score, they can be given PCI or CABG with equivalent long-term results. Only patients who are having a high syntax score, CABG is a better option as compared to angioplasty for having multi-vessel coronary artery disease. This is a very interesting slide if we get into the details of this slide. This is a 12 or 13-year follow-up of the syntax study called the syntax ES, the Extended Survival Study with Syntax. The syntax patients were recruited in 2005 to 2007. And there, the stent which was used was the first generation drug-eluting stents. These are the patients who have been followed up for multi-vessel coronary artery disease. But mind well, after 2005 to 2007, there have been imaging-guided PCI. There have been more potent antiplatelets. There is the concept of FFR, that is functional testing to ascertain whether there is viable myocardium or no. And with all these things, imaging, intravascular ultrasound, OCT, there have been improvement in survival. So the caveats of the syntax study is that there was no imaging use, no FFR use, less potent antiplatelets. Hence, there were higher risks of stent thrombosis and in-stent restenosis. So now, there is a global risk classification. We combine a syntax score and a Euro score based on low score, intermediate score, or high score. We can derive which patients are at a high risk of restenosis with angioplasty, which patients are at a higher survival with CABG versus angioplasty. So with the help of this score, these all calculators are available online. We can decide which patient would fare better with which modality of treatment. There was a freedom trial in which they included diabetic patients having multi-vessel coronary artery disease, and these patients were given sirolimus eluting stents or paclitaxel eluting stents versus CABG. In diabetic subsets, it was proved beyond doubt that CABG has better long-term survival as compared to angioplasty. Next, we come to the concept of functional testing, that is the functional syntax score or syntax 2. FFR guided syntax scoring, what we observed with functional imaging is that while doing FFR is a simple test in which we do pressure wire hemodynamic, testing the pressure distal to the lesion and proximal to the lesion. The ideal ratio should be 1.0, but if it is less than 0.8, it is suggestive of inducible ischemia. So with FFR functional testing, we realized that with the regular syntax score, only 1/3 of our patients were low risk. However, with functional testing, more than 60% patients were low risk. So it was found that higher number of patients were in low risk and medium risk and could be offered both forms of treatment. So then comes the concept of the heart team, wherein the surgeon and the cardiologist sit together and discuss which modality of treatment is better for which patient. Angioplasty, sure shot for ST elevation myocardial infarction, non-ST elevation myocardial infarction, the culprit lesion, patient in cardiogenic shock, left main lesion in ostium or shaft, or patient having lesions after bypass surgery. CABG, sure shot for distal left main and multi-vessel disease with a high risk score. The heart team needs to discuss for many other points. Is there a concept of hybrid revascularization in which we can offer the best of both worlds to the patient? Can we give left internal mammary artery to LAD graft as CABG and circumflex and right coronary artery angioplasty to the patient? Yes, these therapies are being offered in the West, and soon they would be offered to our patients too. We need to understand one more concept called the residual syntax score. That means if by CABG a certain lesion is not revascularized, or with angioplasty a certain lesion is not revascularized, those patients would have a lesser survival. So this is the curve of residual syntax score. Patient which is completely revascularized will have a very good survival versus a person who is having incomplete revascularization. Over a period of 3 to 4 years, these patients would have a reduction in survival. So now comes the concept of shared decision making. This is my second last slide. One more minute, please. In which we need a patient-centric approach. The physician, the cardiologist, the cardiac surgeon, patient, family, caregivers, as well as the paramedical staff come into play here to give the best sort of treatment to the patient. All the pros and cons need to be discussed with the patient and the family and empower them to take the correct decision. Well, this is a graph of the international guidelines from ACC AHA. This is a summary of what I have just mentioned, but to summarize, patient information and consent is most important. Most patients want to run away from a bypass surgery, but it is our duty as healthcare providers to help them in shared decision making with a heart team approach. Thank you so much for your patient hearing.
Thank you.
Teacher of DNB medicine students. Welcome to the stage.
Uh, very good afternoon to all of the audience, respected DG Madam, PCMD Madam of both railways and many other honorary dignitaries sitting here. I can see full house till the, full house. I can really see. We are about to end the sessions and still we can see. And I am really honored. I am the product of this Jagjivan hospital. Basically, I want to tell you all of you. I'm the first student to pass DNB cardiology, and I'm very proud. And I really thank Dr. Shishi sir also to give me this opportunity to have a talk in this. Though I was okay, I would like to rush through. This is not a very interesting topic because my talk is already simplified by Dr. Harish Mehta sir. And what's new, I will be talking about this Takotsubo cardiomyopathy. I'll start with topic today's talk. I would like to include these topics like historical perspective, nomenclature, definition, and many other things to come. So how to see the big picture is not easy as you would think. So historical perspective to start with and how this nomenclature came. It is now almost 30 years since the Japanese investigators first described this terminology, Takotsubo cardiomyopathy. So in first and original description of these Japanese, they described this Takotsubo in 1990s. This was described mainly in aging women, and they thought it is due to an impact of multivessel coronary artery spasm. So why this term Takotsubo? Because what the morphology of the LV we see, that is LV apical ballooning, which resembles to the traditional Japanese octopus trap, and that's why they came with the word Takotsubo. So can any disease have so many nomenclatures? Okay, since 1990, we till almost 2024, we have evolved with these almost terminologies for the same disease. So basically, 3 terminologies, Takotsubo cardiomyopathy, then broken heart syndrome, and Takotsubo syndrome. These are the most commonly used terminologies till now. So everyone knows Valentine's Day, happy heart and all, and with the stress, heart breaks down and people go into stress. So media portrayed this syndrome as a broken heart syndrome, which is actually not true. Okay, so that is the media given term. So basically they came with the new terminology. It's not, and cardiomyopathy was difficult to understand. So they converted this into the Takotsubo cardiomyopathy. So coming to the definition and diagnostic criteria, there are, since 2003 till 2018, so many criteria have come up. So basically still many a part of the world, they use Mayo Clinic diagnostic criteria, which are simple and very easy to understand. But we need to understand what has changed from this Mayo Clinic diagnostic criteria to Intertac criteria. ESC and Intertac both are latest one, but we will be sticking to Intertac criteria, which has changed our approach to this stress cardiomyopathy. So these are the Mayo Clinic criteria, which says there should be new ECG abnormality, absence of obstructive coronary artery disease, and transient apical akinesis or dyskinesis. So this absence of obstructive cardiomyopathy was a major criteria for this diagnosis. And they said that patient should not be having some conditions like head injury, intracranial bleed, especially pheochromocytoma, myocarditis, and hypertrophic cardiomyopathy. So now what comes new? So these are the common, if we consider this Mayo Clinic criteria and Intertac diagnostic criteria, these are some common parameters and some different parameters. So by defining this, significant coronary artery disease is not a contraindication to stress cardiomyopathy. This is what given by this Intertac diagnostic criteria, and also they said pheochromocytoma should not be a contraindication to this. So these are the different criteria, and we can see right from transient apical motion abnormalities to some stressor, coronary artery disease, recovery, and especially postmenopausal women, their different parameters are incorporated differently in different criteria. So our main topic is preventive cardiology. So I'll be giving more stress on one slide. This is the many triggers of stress cardiomyopathy, like emotional and physical stress factors precipitating cardiomyopathy. So if we see here, emotional triggers, mood disorders like depression, suicidal attempts, divorce, anxiety disorders, post-traumatic stress disorders, or moving to another city. These are the emotional triggers like illness in the family member, death of the family member, euthanasia of the pet, debt, bankruptcy, jobless, retirement, argument with family members, flooding, earthquake, storm, car accident, even happy heart syndrome. This like, if you are winning a jackpot, positive job interview, birth of a child, wedding, these are also seen as emotional triggers for the stress cardiomyopathy. And when we talk about physical triggers, like many a time we keep on concentrate on this like neurologic parameters like stroke, epilepsy, migraine. We treat that parameter as a stroke, but we need to realize that condition per se has a stress behind that, and that can lead to dysfunction of the heart. So like respiratory diseases, digestive, infection, oncologic, and others, so many such, like giving birth to a child also. So how can we forget our COVID? Jagjivan Hospital has worked exclusive COVID hospital and has a very great thing. That time everyone was in stress. So when we are talking about the stress cardiomyopathy, we cannot forget this COVID. So few words about Takotsubo cardiomyopathy and COVID-19. So the new terminology actually has come at that time only, like COVID-Subo. So COVID-19 and octopus both go hand in hand. How they go hand in hand? Because COVID, that time, rather than a disease, there was a tremendous stress, fear all over the community. Okay, many of the almost 90, I would say 85 to 90% of the people recovered without any scratch also. But unfortunately, whoever lost the life, I think 50% of them maybe have lost because of the disease, but 50% might have lost because of either they were not able to reach the hospital for their original diseases or maybe stress-related complications. So this virus has two distress situations, empower each other. Like if you have this virus is causing stress, this can lead to stress cardiomyopathy, and virus per se, due to inflammation and his respiratory dysfunction, can cause a disease. So if you have a patient who might be more emotional, please pay attention to the psychological support, which is very important to them. And it is very good to say that we had that time appointed clinical psychologist in our hospital for the counseling of these COVID patients. So coming to the pathophysiology, it's not new, just it's a sympathetic drive through the adrenal medulla, and which leads to sympathetic overdrive mediated multivessel epicardial spasm, microvascular dysfunction, and lipotoxicity and inflammation. This is how that stress giving rise to inflammation. And clinical presentation, initial workup, we need to understand this, whatever presentation patient comes with, like chest pain, dyspnea, syncope, we cannot distinguish Takotsubo from STEMI at presentation. So both mimic same on presentation. And how we're going to understand, because ECG also shows ST elevation, ST depression, T-wave inversion, QT prolongation. So all ACS parameters like STEMI, NSTEMI, and unstable angina, anything can mimic this stress cardiomyopathy. So which lab parameters help us? Because if we do mainly two parameters like troponin I and NT-proBNP. So if we take their ratio, this NT-proBNP to troponin I ratio is very tremendously high in Takotsubo cardiomyopathy, because troponin is not that much elevated in stress cardiomyopathy, what we see in acute myocardial infarction. So this in AMI, his ratio is in hundreds and the ratio is in thousands in stress cardiomyopathy, to be understanding better. So diagnostic criteria, so I would say echo shows maybe apical, some RWMA present, which can be present in both stress cardiomyopathy, AMI. And then comes the role of coronary angiography, especially left ventriculogram. So if we are finding no coronary artery disease, we can go to the directly left ventriculogram, and we can, this is the gold standard which can diagnose us. So we can see this apical ballooning, which is the hypercontractile basal segment, and apical ballooning. There are other ways. See, this is how the octopus, this trap is laid in the sea, and the octopus is catched. That's why this trapping for Takotsubo cardiomyopathy. In systolic phase, nicely seen, this appearance. In diastolic phase, there is a normal thing. There are variations. I won't go into this many difficult like apical, which is most commonly seen, then mid-ventricular, basal, and focal. So also cardiac MRI is helpful, which does not show late gadolinium enhancement. Then these are the strengths and weakness. What is the differential diagnosis of this? So what we are talking, there is a STEMI mimic this stress cardiomyopathy, and we are saying that there should not be some obstructive coronary artery disease. So this can also be mimicked in the form of non-obstructive coronary artery diseases also. So they have summarized this criteria, like if we come more than 50 of this criteria, it can diagnose us stress cardiomyopathy with a specificity of 95%. And coronary angiography, I said, and biomarkers will help us. What about the new guest, Minoca? Myocardial infarction in normal coronary arteries. Some other speaker is going to talk on this normal coronary artery disease related to infarction. So we want to say that just absence of coronary artery disease, does not say that patient does not have this MI. So patients can still present with a STEMI, with a Minoca. It's not always a stress cardiomyopathy. And the gold standard to differentiate is only cardiac MRI. So I'm going, does the biological sex matters? Yes, from wound to tomb. These females are more affected, like NSTEMI is most commonly seen in women, and especially postmenopausal women are most affected. So these are the ACS complications, basically because stress cardiomyopathy is just a disease. Ultimately, patient will die out of these complications like ventricular rupture, arrhythmias, ventricular apical thrombus, and mitral valve complications. So these are the death is seen in almost 1 to 5% of patients, and acute heart failure is the most common presentation of this stress cardiomyopathy. Outcome will depend on the different parameters, which we see. If the EF has dropped down during stress cardiomyopathy, outcome will be unfavorable. We see some early outcomes and late outcomes. Into that, death is predominantly a late outcome, usually. And what will happen? Can it recurrence happens? Yes, we can see 1 to 2% of the annual recurrence with this stress cardiomyopathy if the stress continues to be with the patient. So these are the different, and last is the treatment. So it's just a symptomatic treatment. We need to classify patients on low and high risk categories, and these are the different parameters given to classify patients on the different categories. And there are some acute complications. We need to address this acute and chronic complications. We need to see ACE inhibitors, beta blockers if the patient is having like beta blocker if the patient is presented with cardiogenic shock, and antithrombotic anticoagulation if the patient presented with LV thrombosis. These are the only parameters shown to be beneficial. So thank you so much for this lecture.
Thank you. Yeah. I now request chairperson to hand over memento to Dr. Mangesh.
Actually, when I asked Dr. Mangesh which topic you like to have, he told, in my JRH career of DNV, I have enough stress-induced cardiomyopathy. So I have a lot of experience. So let's share with my PCMD ma'am, both are sitting, and I think both CMD were there. So he's a product. And really, he had done a marvelous job during COVID era. When I was telling him COVID, he was crying, go to PCMD. So this, during his practical exam, he called me, sir, I'm having stress-induced cardiomyopathy. So it's okay. Thank you all.
Our next speaker is Dr. Rajiv Chu. His topic is myocardial infarction with normal coronary. I now request chairperson to briefly introduce our next speaker. Thank you.
Welcome, Dr. Rajiv Chik. He has done his MBBS DNB medicine, DNRB cardiology, currently working as senior DMO, cardiologist and physician in charge of cardiac and AMP medical unit of 60-bedded division hospital, Agra, Kent, Agra. Formerly, he was at Department of Cardiology, Max Super Specialty, Pratapgarh, Delhi. And he has worked in Department of Medicine in Baba Saheb Ambedkar Hospital, Rohini, New Delhi. AIT Clinic Department of Medicine, AIMS, New Delhi. Department of Neurology, GB Pant, New Delhi. And also Department of Critical Care, Shri Ramurthy Smarak, Institute of Medical Sciences, Bareilly. Welcome.
Good afternoon, DG ma'am. As we are arriving at the conclusion of our conference, I will not take the much time as we are all awaiting the lunch. So my topic is Minoca, which was earlier a benign condition, but now it has again came to existence because of its not so benign nature, and it's having the more of a complication, which was earlier thought it does not have a complication. So what does Minoca says? Minoca is the myocardial infarction in the absence of obstructive coronary arteries, which was first documented 75 years ago. And initially it was described as MINC or myocardial infarction with normal coronary arteries, but later on it has been designated as myocardial infarction with normal coronary arteries. So the rationale for defining the Minoca as a distinct entity is based on the clinical observation and parameters. Like patients with Minoca generally have a better prognosis than with acute myocardial infarction coronary artery disease. And multiple atherosclerosis and non-atherosclerosis causes with heterogeneous pathophysiological mechanisms can cause Minoca. And unlike AMI associated CAD, there is paucity of dedicated case series as well as dedicated guidelines for the Minoca patients. So the prevalence of Minoca, there was never a study for Minoca itself. So in the retrospective studies, which were done by David Halal, and it was published in Angioplasty in ACS patients, STEMI as well as NSTEMI patient, the prevalence was 5% in the, of the Minoca patient, which were later subsequently confirmed in the AMI registries and large meta-analysis. My talk is mainly what is Minoca, when to diagnose Minoca, who is at risk of Minoca, and why we should diagnose the Minoca and how to manage, and what is the future perspective for the Minoca patient. So as it has gained the recognition, so in 2017, European Society of Cardiology has came with a scientific paper, which was subsequently AHA has also come in the 2019, and they have sent a certain diagnostic criteria for the Minoca patient, which includes the three mainly diagnoses we have to do by the working diagnosis of Minoca, and we have to take the acute myocardial infarction as per the fourth universal criteria of the diagnosis. And there is a rise and fall of the cardiac biomarkers, troponin I, along with the signs and symptoms of the coronary ischemia, development of new pathological waves, or RWMA on the echocardiography. Along with it, on coronary angiography, there should be non-obstructive coronary arteries, like there should be less than 50% obstruction in the coronary arteries. And there is no specific alternate diagnosis for the clinical presentation. So when to diagnose Minoca? Minoca is a working diagnosis, means patient is presenting with the ACS, and after coronary angiography, there is no obstructive CAD, and there is no overt cause for the Minoca. And if there is a presence of myocarditis, so we have to avoid the Minoca diagnosis. This is the traffic light sequence for the Minoca. Like when a patient presents with a rise and fall of coronary, means acute ACS presentation, and on angiography there is less than 50% lesion on the angiography, we have to again relook the patient history and the clinical context. And if there is associated systemic disorder like sepsis, pulmonary ambulance, cardiac contusion, or other non-cardiac causes of troponin I, we have to exclude the diagnosis of ACS and have to treat the patient accordingly. After it, if we have to again recheck our coronary angiography by view of coronary OCT or IVAS, and again relocate. So sometimes we find a small vessel which is we majority see in the epicardial artery, but in the small vessels we cannot go. So sometimes we relook it by the way of IVAS or OCT, and we can diagnose it again in the obstructive CAD. And as my previous presenter has talked on cardiomyopathies like Takotsubo syndrome and myocarditis, which are the mimickers of the Minoca patient. So if we exclude all this, then we come to the Minoca diagnosis, and it is the heterogeneous diagnosis, which may include the plaque distribution or spontaneous coronary artery dissection, or coronary spasm, or the microvascular disease. The microvasculature causes the less than 0.5 millimeter coronary arteries, which causes the 70% of the coronary resistance. So who is the patients which are at high risk of Minoca? These are the differ from the patients of acute myocardial infarction. Minoca patients are usually younger patients, which are 55 to 58 years of age, and more than 50% of Minoca patients are female. And the traditional risk factors are Minoca patients have a lower prevalence of dyslipidemia, which is well documented, but other risk factors are seen less frequently but not been documented in the studies. So why should we diagnose the Minoca? First, to better diagnose it, to clinically exclude the other DDs, as well as the prognosticate the patients for Minoca. As sometimes we say to the patient that you have got normal coronary. So patient is started again, patient doesn't follow the guidelines as well as the medication and doesn't follow the lifestyle preventions. So to avoid this, we have to ask the patient that you have got a normal coronaries, but it is not so normal, which was earlier thought to be. So how to manage Minoca? It is the clinical assessment, then angiography, and then LV angiography. And CMR imaging, as has been told by the previous presenter, the CMI imaging is the essential in case of the Minoca patient to exclude the cardiomyopathies, as well as to find the subendocardial myocardial infarction, which is observed in the 24% of the Minoca patient presenting with the AMI. So the management of the Minoca patient, as we do the other ACS patient, first we have to do the emergency supportive care, then a working diagnosis approach by the traffic light sequence, then we have to give the cardiorespective therapy irrespective of the cause of Minoca, then we have to do the cause targeted therapies. So these are the Minoca mimickers, and we have to treat the patient as per their cause. Like if there is on re-evaluation of the coronary angiography, if we find some severe branch stenosis or embolus obstructed the branch, then we have to treat him like a proper ACS with the DAPT along with the statins and ACE inhibitors and beta blockers. If there is spontaneous coronary artery dissection, we have to give the aspirin beta blocker plus minus clopidogrel. While in cardiomyopathies, as told by the earlier presenter, we have to treat according to it. While patient presenting with ischemic presentation of Minoca, then we have to, in the plaque disruption, it has to be treated like a ACS. While coronary artery spasm should be treated with a calcium channel blocker or vasodilator therapy. Along with, we can add a tricyclic antidepressant to it, which may benefit the patients, which are seen in the some studies, small label studies. And in the coronary microvascular dysfunction, we have to give the anti-angiolate therapy and unconventional anti-angiolate therapy like arginine, ranolazine, dipyrimidolol, and other therapies. While if the patient is presenting with coronary embolism or thrombus, we have to give the anticoagulant therapies. So the prognosis of the Minoca patient, earlier it was shown to be benign prognosis, but later on when we find the retrospective studies, it was not so benign, which was thought to be. It is better prognosis than the acute myocardial infarction, but still it has got its own prognosis. And the prognosis depends on the underlying cause. Like in the Virgo studies, there was 16 patients was Minoca, had similar 1 month and 1 year mortality rate as comparable quality of life measures with the patient of AMI. While in Korean infarction studies, the Minoca patient has a similar risk of major adverse cardiac events as per the AMI CAD patients presenting with double vessel or single vessel disease. And approximately 25% of Minoca will experience angina subsequent 12 months, which is similar to the frequency reported in the patient with AMI CAD. And in the action registry, the in-hospital mortality rate was 1.1% in the Minoca patient, but there was no sex difference was observed. While in the New Zealand registry, the 4.6% of the Minoca patient has been death or AMI, while similar 2.2% of the age and sex matched population without the cardiovascular disease or diabetes mellitus. So the predictors of in-hospital mortality in the Minoca patient was similar to like AMI CD patient, like higher age, higher troponin levels, associated other systemic illnesses like renal dysfunction, if patient is presenting with tachycardia or high blood pressure or peripheral artery disease. Out of is the presence of ST segment elevation on ECG and presentation with heart failure or shock were more strong predictive of in-hospital death among patients with Minoca than among the patient with AMI CAD. So what is the next for Minoca? First, we have to identify with the help of, like nowadays we have got a very good troponin assays which can diagnose even a very, very minute amount of troponin also. We have got a cardiac MRI centers are opening up and we can have it. And along with that, we can have a coronary imaging along with physiological studies. Then we can do the hematological testing and provocative testing with the acetylcholine, which can induce the coronary artery spasm, and we can rule out this. And we can have a Minoca specific international classification diseases, which is the 10th revision course, which was suggested by in the 2019 Scientific Association paper of AHA. And additional research to define the optical medical therapy for Minoca patients, especially for those in whom underlying pathological mechanism for MI has not been identified. So the summary for Minoca patient is it is a distinct and clinical diagnosis with many different pathophysiological causes, and it is essential that healthcare professionals become familiar with this syndrome so that patients are appropriately identified and treated. So I want to say that Minoca, which was earlier a benign, but not so benign. So we have to keep in mind whenever we are having the patient with normal coronary arteries and raised biomarkers. Thanks.
Thank you, sir. I would now request our chairperson to present memento to Dr. Raju Chuk.
We started the show with triple vessel and MI, now ends with MI with a normal coronary. So the message what we are leaving here is any patient having a normal coronary can lead to any form of acute cardiovascular illness unless until proved. So we can have anything wrong, but we have to have proper diagnosis.
Thank you. I now request Dr. Ashok Kumar sir, CSS JRH, to honor our chairpersons with a memento.
Now, Dr. Kishore, please.
After this, we will be having Dr. PJ Haldar, GI surgery oration. And I now request Dr. Kishore Jain to come on dais and take over the mic. Thank you.
Dr. Haldar sir, now who got retired last year, on his oration we are having our extreme speaker who is a product of KM and who become the dean of KM. This happens very rare person in the world. Started MBBS, started his MD, started his post-graduation, super specialist from the KM. He's none other than anybody. He's Dr. Hemant Deshmukh sir, and he also had a lot of contribution to our JRH also. So we are proud having him here only. And now I request Dr. Kishore to speak about Dr.
Good afternoon to DG Madam and PCMD Madam. It's an honor to me to just give a brief introduction for PJ Haldar sir oration. PJ Haldar sir, as oration has been instituted in Jagjivan Railway Hospital, who was instrumental in the setting the Department of Surgical Gastroenterology in Jagjivan Ram Hospital. He did his post-graduation MS General Surgery from St. GS Medical College and KM Hospital in 1985. He joined Jagjivan Ram Railway Hospital in 1985 and he was worked in various capacity in Jagjivan Ram for almost 37 years. He is superannuated as a chief consultant in September 2022. He has been HOD for almost 20-25 years in Department of General Surgery. Then he was a head of the department in the surgical gastroenterology. The turning point which are in his academic year, which he is inclined to the GI surgery. Was first he got a Tata Memorial IASG fellowship for 2 months, and then he was as a visiting surgeon at Heidelberg University, Germany, which is one of the Mecca Institute for the pancreatic surgery. These were the two turning points, which leads to his inclination to the advanced complex hepatobiliary pancreatic surgeries. And then the biggest landmark, which all over, not for Jagjivan Railway Hospital, but for Maharashtra and Western India, the getting the sanctioning of the DNB surgical gastroenterology. It was the first seat in Maharashtra in railways in Western India. It was started from 2033, almost 12 candidates, 12 years passed from the under sir, in which 2 were the gold medalists. He has presented numerous papers at various international and national conferences. Various chapters he wrote for the Prem Brooks. Today, the surgical gastroenterology department of Jagjivan is one of the best department in the surgical gastroenterology sector in Indian Railways, not in Indian Railways, but in Maharashtra also. Thank you, thank you. And I with a warm welcome to Dr. Hemant Deshmukh sir to continue his oration talk. Thank you very much.
Thank you so much. JRH has been my place of work also some 15 to 20 years back. And I had a close association with Dr. Haldar then, who encouraged a lot of interventions to be done at JRH. So here I am, Dr. Hemant Deshmukh. Doctor is secondary. Started my education in St. GS Medical College, Mumbai. Did my post-graduation. Again, subspecialized in interventional radiology. I'll not take you through a lot of slides and cases, but I will try to touch upon certain cases where interventional radiology has been a big contributor in saving lives, making the surgeon's life easier, and helping all the clinicians to treat patients. This entire slide summarizes my journey from 1977 till today. This picture shows that I was the ex-dean of KEM Hospital, and this was exactly during the COVID. And you can imagine the amount of COVID patients that KEM handled, and it was an exclusive critical care patients hospital. We never admitted normal routine COVID patients, but it was entirely a critical care, critical bed hospital, and we had something like 600 critical beds. So the entire, the entire job of a radiologist turning into an interventional radiologist and then into a COVID specialist will demand a lot of reading, a lot of interaction, and a lot of feet to the ground. And this was me during the COVID. Academic qualification doesn't really matter when you become a dean. But the number of publications, why I'm trying to tell you the publication? Because JRH is also an academic institute. When I say I have H index of 18, what does it mean? Anyone wants to tell me? I have H index of 18. This is the interest I want to generate in the audience. Forget about interventional radiology, forget about radiology, forget about patient care. But if you are in an academic institute, H index will matter. So H index, probably everybody is on Google. Everybody has a Google ID. Just go into Google, type Google Scholar. Don't check for my Google Scholar thing. It will be your own Google Scholar, and check your profile. Go into Google Scholar, check your profile.
Done? Shishir, I'll take 10 minutes. Whenever people are hungry, I'll close down. How many of you checked? Anybody's H index between 1 and 10? I'm just trying to ignite some kind of interest in academics. Everything else is in the books, everything else in the lectures. So H index means my H index is 18. When I say H index of 20, it means that it is very good, excellent. So I'm below excellent. Anything between 20 and 40 is outstanding. And all Nobel Prize winners have H index of 30 and above. When I say H index of 18, it means at least I have 18 articles to my credit, for which 18 citations have been done by other authors. At least 18 articles where 18 citations have been done on each time. Then total number of citations is 1253. That means my articles have been cited almost 1253 times in literature. So if you are in a medical college, if you are in an academic institute, I think you should concentrate on H index also apart from patient care. My areas of interest, interventional radiology. Harish Mehta was always trying to point fingers at me. Dean sir, tell me what is this? Dean sir. So I gave up my gynac seat to one Dr. Mahesh Gosavi. I don't know anybody remembers. So he approached me. He said, Hemant, you have to give up gynac. If you don't give up, I will not get gynac. I was the last chooser and radiology nobody preferred. I took up radiology. And this was an era where there was no ultrasound, no CT, no MR. And my guide then in gynac was supposed to be Naina Dastur. Everybody remembers her. So I gave up gynac for radiology. And I took up radiology as a passion. I didn't want to become an X-ray kadmi during 1984. Black and white images. I didn't bother much. I wanted to become a clinical radiologist. I wanted my hands to treat patients, not write reports which the clinician doesn't understand. Correlate clinically. Doesn't make much sense. All CT, MR reports will say, clinically correlate karo, sir. No. So this is a bond between the patient, the doctor, one who is treating, and the other who is consulting a doctor. That is doctor consultant is a radiologist. So even diagnostic radiology I didn't like. So since 1986, I am into interventional radiology. I always wanted to puncture biliary radicals. I always wanted to puncture pelvic ileal system. I always wanted to puncture an artery or a vein or any hollow viscous in the body. You name any hollow viscous in the body, I can enter that hollow viscous percutaneously. So we started in 86. Interventional radiology in KM started much earlier, that is 82. But it was more of, diagnostic angiography. So basically we are plumbers. As cardiologists also they are plumbers, remove the dirt. But they don't stop bleeding. We stop bleeding. They only do a plumbing job. We seal the bleeding also. So the entire principle of interventional radiology and what we call ourselves as peripheral cardiologists also. Why? Because the heart and the rest of the blood vessels are interrelated and we work together so the patient's life is much enhanced and the patient has a happy life.
You read what is written there, visualize but do not try to fix it. So this was the order of the clinician. ज़्यादा काम मत करो, खाली angiography करो, मुझे दिखाओ क्या गलत है. No, we started treating the patients also. So that's how interventional radiology came into picture. As I said, this is peripheral cardiology also. So there's an overlap of atherosclerotic disease, coronary artery disease, cerebrovascular disease, gangrene, mesenteric angina, everything else is included. One cannot, remain isolated from the other. Entire atherosclerotic disease, which is a global disorder and has a localized manifestation, which is called as either coronary artery disease or stroke or mesenteric angina or gangrene. So here we are to save limbs, salvage limbs, and prevent amputation and lives. So a word about preventive cardiology, everybody has heard. Now this is something which is called as preventive radiology. So everything else together, JRH or Western Railway Hospital or Indian Railways has a big population who comes for diagnosis, who comes for cardiovascular health checkups. I would suggest only 3 things. Have a family history, have CRP done, especially HSCRP. Obviously, I don't know whether JRH has a CT scanner, but having a CT calcium score is one step towards preventive cardiology. And a simple ankle brachial index. Anybody has touched their dorsalis pedis of late? As you go beyond 40, 50, try and touch your dorsalis pedis. If your dorsalis pedis is good, the chances are that you will not have atherosclerotic disease for a long time. So that's ankle brachial index. The highest systolic pressure between the ankle and the brachial. Normally it should be 1. Pressure anywhere in the body is supposed to be equal. But if the pressure of the ankle goes down, it's imminent danger. It's a sign that you should see to it that you investigate yourself for atherosclerotic disease. Okay, the first slide, if anybody watched my H index, I index, there was something which is written as innovations. There was something which was related to research in interventional radiology. This picture shows that this is a CT angio, aorta. This is the celiac artery. This is the superior mesenteric artery. Not seen it? This is the celiac artery. This is the superior mesenteric artery. That's occluded at the ostium. So ostial stenosis of the superior mesenteric artery. One simple question to the audience. What does the patient have as symptom? Mesenteric angina, pain in abdomen, which is called as sebophobia or cetophobia, okay? Which means that the patient will not eat food for the fear of pain. Very simple concept. Suppose now an obese patient has mesenteric angina, what will happen? Will become thin, will lose weight. So all patients with mesenteric stenosis lose weight to the extent of 10 to 15 kg. So our brain started working, mine and Dr. Kranti Kumar Rathod, who was my colleague in 2010. So why can't we have stenosis induced in an obese patient? Simple concept. So the patient will lose weight. Why subject him for surgery? So we devised a stent, we devised a medical device wherein we induced artificial stenosis in a blood vessel. Does anybody know that there is a medical device which looks like a stenosis? No, we invented that in 2011. We got US patent in 2020. That was just 2 years. See whether we can help obese patients lose weight. Simple concept? Okay. There's one more easier way to treat obesity. Why? Just embolize the left gastric artery. This is the left gastric artery coming directly from the celiac artery, first branch straight. Just embolize it. We interventional radiologists are very, very efficient in blocking blood vessels. Okay? And that too diligently. See to it that we do not do any non-target embolization. And once we occlude this artery, that is the left gastric artery, patient starts losing weight. Very simple, straightforward. Why undergo so much bariatric surgery and complications associated with bariatric surgery? So as I said, we occlude blood vessels, and this is a cardiology conference also. We venture into the pulmonary circulation also, where there is more blood not being distributed, the lung not getting oxygenated, pulmonary AVM. This is a point to be noted by the anesthetists also. Any anesthetists around? Okay, great. So watch the monitors. Not there. What is the SpO2? 57. Why? Because the patient has pulmonary AVM, not getting enough oxygenation. So this patient, right side pulmonary angio, a big AVM here, multiple AVMs. So what we do, your AOT or AOD device, Amplatzer device, it's a vascular plug, float it exactly in the communication between the artery and the vein. One here, one more here, 2 devices, 3 devices. The oxygen saturation comes to 85 now, on table. Do more. One more there at the upper lobe. See the redistribution of blood vessels now. See that more pulmonary artery vasculature is getting oxygenated. No AVM, oxygen saturation has come back to 100 exactly on table. So this is the way that you can actually make a difference by floating small vascular plugs, by blocking blood vessels. Again, once you achieve 100% oxygenation, what remains is a good follow-up and see to it that the oxygen saturation remains up all the time. So as I said, we can embolize or occlude blood vessels anywhere in the organs of the body. We can go into the cerebral circulation. We can go into the what you call as pancreatitis-induced pseudoaneurysms of the splenic artery, gastroduodenal artery. Anywhere in the body, we just go there and have a surgical principle of occluding the blood vessel proximal and distal to the aneurysm and see to it that you segregate the entire circulation from the aneurysm and cause a devascularized space. So embolization is practiced almost everywhere, including cerebral aneurysms. I'll not go into picture. There are certain iatrogenic complications associated with lap chole. This is a lap chole done with a large cystic artery aneurysm. You can see the hepatic artery branching and then a large pseudoaneurysm with branches arising from it. And what we require here is just go distal, just go proximal and occlude the blood vessel exactly like you ligate. So when a surgeon ligates the blood vessel, it is called as ligature or ligation, and when we do it, it is called as internal ligature. So what a surgeon does from outside, we do it from inside. Okay, multiple blood vessels. Gunshot injuries, entire peritoneum loaded with blood, liver is floating. There is a superior mesenteric artery and a superior mesenteric vein fistula. No surgeon should venture into this because the failure rates are much higher. You just go in, embolize the feeders in the superior mesenteric artery, and what you get is a clean liver with no collection. Similarly, multiple injuries to the bowel. Again, rational use of vascular plugs there also, treating a inferior mesenteric artery, inferior mesenteric vein fistula. One last slide, or maybe 2 more slides. This is a large hemoperitoneum in a young girl. Any diagnosis, anybody? This is what you see is a large hemoperitoneum. This is a CT angio of the same patient. I'm just trying to ignite mind, see to it that you don't fall asleep. Your hunger pangs are much into action now. This is a abdominal aorta. This is the infrarenal aorta, occluded totally. No blood vessels anywhere. How do I go inside now? How do I go? Femoral arteries नहीं है. Carotid से जाने का, carotid arteries से भी नहीं जा सकता. Brachial, axillary, no, all occluded. So we cardiologists and interventional radiologists are trained so much that we can go through occluded blood vessels, no? That's our skill. So go through the occluded blood vessel here and occlude the artery which is the culprit artery causing massive hemoperitoneum. And that was the large aneurysm with lot of clots around. Embolize that with coils, glue, whatever you want, and then treat the patient. Okay? This is one more domain of a gastroenterologist and a GI surgeon, that is Budd-Chiari syndrome or a inferior vena cava septum or a membrane. So, no IVC, still puncture the IVC, go through it, go into the RA, dilate slowly, and keep the IVC patent with a large stent, and that almost decongests the entire liver as well as the portal circulation. Simple procedures, worth taking a risk, and curative enough in nature. One more diagnostic thing which a surgeon needs sometimes is where is it bleeding from? And this is where methylene blue angiography helps the surgeon to tackle exactly which part of bowel to be resected. 4-year-old male child. So age is no bar. Any kind of patients, any age of patients can be treated with angioplasty and stenting, multiple stents in the hepatic veins, or if there are no hepatic veins, we directly puncture the IVC and get into the portal vein. Imagine mentally where is the portal vein there is, and where is the hepatic vein which is occluded, where is the IVC. So that's a blind channel, that's a place where we have that idea of going where to where, puncture the IVC, get into the portal vein and connect a shunt or a stent graft so that there is now a deviation of portal venous circulation directly into the IVC. Clinically, definitely the patient improves very well. I'll not show a lot of pictures. Last slide for the gynecologist. Because we don't get any fibroids from gynecologists. Unfortunately, gynecologists do not want to refer patients with fibroids to an interventional radiologist. And this is where we come into picture. Large fibroid, these are all hypervascular fibroids. With comorbidities, everything related to obstetrics and gynec we can tackle, including PPH, placenta accreta, percreta, everything. Yes. So I have been coming here to treat patients who are in emergency to control bleeding. And one humble request to the gynecologist, if it was your relative, please refer to us. If it's your patient, you can treat either by doing myomectomy or hysterectomy. Thank you so much.
Thank you, sir. Thank you for your nice talk, sir. In the memory of Haldar sir, I request our PCMD mom to offer a flag and oration. Now I request PCMD madam to offer a token of love, sir, and I request Haldar sir and madam to come to the stage. Haldar ma'am, please. Thank you, sir.
My sincere thanks to SAMO for giving me the opportunity for instituting this oration in my name. GI surgery has been my passion since the time I have joined JRH as a surgeon. And as I remember, the first pancreatic duodenectomy was done in JRH in 1989. That was the first one. Incidentally, it happened to be my own father, who survived for almost 30 years after the surgery. So that goaded me onto GI surgery. And as stated that in 1996, I went for the fellowship in Tata Memorial. And that gave me a further fillip to improve the GI surgery services. And we were the first hospital in whole of Indian Railways to acquire a advanced laparoscopic surgery set. So that further added to the GI surgery. And 2003, of course, was a landmark that we achieved the first DNB accreditation for GI surgery in Mumbai, Maharashtra, and Western India. And the only Indian Railways hospital so far. Unfortunately, due to the lack of faculty, we had to discontinue it after my superannuation. But I sincerely hope that it is again restarted. Possibly one more GI surgeon, if he or she comes into the Indian Railways, posted in GRH, then that can be restarted. Once again, thank you all for being here and giving me the opportunity to be present here. And my sincere thanks to Dr. Hemant Deshmukh, whom I know him for many years from KEM as well as an interventional radiologist in JRH. He has cut his lecture very short. He had many things to say, but maybe just pre-lunch he did not want to extend it further because the timing was like that it was pre-lunch. But none the same, there were very interesting things which I also learned. And the audience here definitely has gained a lot with his lecture. And it was a pleasure to listen to him. And thank you all once again. Thank you.
Thank you, sir.
Thank you. My team in JRH, SAMO, of which I was a founder member when we started. So that gives me a great pleasure to be a part of JRH and part of SAMO. Thank you all.
Thank you, sir. Now we come to the end of our conference. Now we are reaching at the valedictory function. Now I respect my DG ma'am to be in the stage to have award ceremony. Now I request Pradeep sir, Dr. Pradeep Rana, who is head of the Department of Pediatrics, to do the honor of announcing the awardee.
I used to refer patients to JRH from Eastern Railway when I in early period of my posting in Eastern Railway. अच्छा, but फिर भी price ना शक्ल फोटो वगैरह लेना पड़ेगा.
बार-बार नहीं लगेगी, सारे पेन एक साथ रख के रखो.
Price distribution देना है ना. चलो start.
Good afternoon, ma'am. In our conference, there were 5 free papers and 22 posters were presented in the conference by the postgraduate students of JRH. It is my immense pleasure to have DGRHS madam, who will be giving the honor of presenting the prizes and certificates. I would like to start with the free paper presentation. The first prize goes to Dr. Prashant Salve of Cardiology. The second prize goes to Dr. Dhanasri Mistry from Department of Medicine. The third prize goes to Dr. Atiullah Khan from the Department of Pediatrics. Now coming to the poster presentations, there were 22 posters of very high standard, and out of that 3 were selected. It was a very difficult job. And the first prize for the poster goes to Dr. Vaishnavi Ganeshan from the Department of Pathology. Vaishnavi, yes. This is Dr. Vaishnavi Ganeshan from the Department of Pathology. First prize. Second prize goes to Dr. Sanketa Lakhande from the Department of Ophthalmology. Sanketa. Thank you, sir. The third prize is shared, and I'd call Dr. Isha Chheda from the Department of Medicine and Dr. Mihika Sarvate from the Department of Surgery. Yeah, I'd say Dr. Mihika Sarvate from the Department of Surgery. She presented a poster in the neurosurgery. Now we conducted a quiz also. The prizes for the quizzes are as follows. The first prize is actually shared between Dr. Hasina Begum and Dr. Amarnath B.B. Are they there?
Near Varanasi.
He's from
He's from Varanasi.
Yeah.
He was supposed to get 2,000, but due to sharing, he got 1,000 only.
From Vijayawada, ma'am. It's South Central Railway.
The second prize goes to Dr. Preeti Gupta.
Dr.
from
Preeti.
JRH. And the third prize goes to Dr. Upasana Mahanti.
Dr. Upasana.
Upasana Mahanti.
Upasana Mahanti.
Later on.
I'm from Baba Saheb Ambedkar Memorial Hospital, Central Railway.
Thank you, madam, and thank you, sir, for doing the honor. Thank you.
We are coming to the conclusion. As a valedictory, I wanted our DG madam to comment on the function, please.
Namaskar, and I must thank the JRH team and also the delegates for making this conference happen with so much of zeal. And the topics were very choosy, and I must congratulate Dr. Raul for enlightening us with so many topics and the subjects which otherwise we would not have come across. Because of your conference, we were enlightened and the speakers were excellent. Your choice was very good. And I think we should add a short session of paper presentations also, not presentation, how to publish the papers, so that we are doing so much of work in Indian Railways, but publishing your work is also important. You must showcase your work, and this helps in inculcating, say, enthusiasm in younger generation also, and the seniors will keep on guiding the juniors, so that all of us together will be able to serve our beneficiaries at the best. It creates confidence in amongst the beneficiaries also, that they are under care of someone who has done so much of work. The institute is having so much of experience with them, so they feel confident and they will not ask for referral outside. So
DNB has said already, all the DNB students are supposed to make a one-paper presentation actually during the course along with their thesis.
yes. So thank you all and best wishes for everyone, and I think this is my last visit as DG, and definitely I will come to JRH as patient sometime, and and I would like everyone to be very updated in her field, and I would like all of you to be a famous surgeon, like surgeon and say practitioner like Dr. Haldar, Dr. Hemant Deshmukh. We are having guiding stars for us, and we should follow them. Thank you.
Thank you very much, ma'am, for the kind words. I would request, ma'am, wait here, Dr. Mansi, आप कुछ बोलना चाहेंगे? Anybody else?
On behalf of delegates.
Anybody wants to make a comment? Juniors?
I want to speak on behalf of all the delegates who have come here. It was a very, very enriching experience being here in Jagjivan Ram Hospital, and the choice of speakers was excellent. The topics were, very, very specialized, but all the same, people like us who are not cardiologists, we could connect. There was a lot of take-home messages that one could glean from the lectures, because, as you grow older, you realize the more you know, the better you are able to communicate. You are able to simplify. E is equal to MC square. It came after a lifetime of learning. So you had the best at the, giving us those presentations at the head end in a very, very lucid manner. I think all of us have benefited very greatly in these 2 days, and people like us who had ample excuses to run away, wahan kaam aa gaya, wahan emergency, none of us have left the hall. We are here right till the very end, and looking forward to a very, and I should say the food and beverages also were taken care of very well. We are going to host a conference in April 5th and 6th, so it has been a huge learning. In fact, there are so many of us from Central Railway keeping an eye on what are the good things that we have to take from here. And believe me, we have plenty to, we picked up a lot from here. So wishing, I hope this will be the first of many. Unfortunately, we tend to do these conferences maybe only once or twice a year. We should be doing it more often. So, and Shishir has been the cherry on the cake. He, Dr. Haldar, where is Dr. Haldar? In honor of Dr. Haldar, he said in memory of Dr. Haldar. So Shishir adds that, adds humor to the proceedings, very heavy proceedings. He adds a lot of humor to it. So it's been a wonderful team here, and it's a lot of learning.
Thank you, madam. And thank you all, because such audiences are also very difficult to get, because every time hall was full, everyone was so attentive. And I just want to add that madam talked about publications. So we try in our institute to have as many which we can. So this year up to February, we had 7 publications in international journals of repute and 5 in national journals. Thank you. Thank you all.
Any shortcoming from our side in hosting this conference, please apologize to us actually. Any shortcomings. We may not be knowing, everybody saying the good things, but there must be something. If you had felt any uncomfortable, anything, please forgive us. Thank you.
Finally, we are thankful to our DG ma'am. Actually, from the session 1 to last session, she was just, this is just an example. Thank you, ma'am. Just regards. Thank you. Now, everybody is requested to have the lunch. And the same menu, that is 4th floor. Okay, thank you. Sorry. Thank you. We have a conference selfie point. We can.
Well, everything is there, ready? Students and IRHs of JRH, SAMO members to please stay back a bit. Call all the students who are not there here. Yeah, they're all there. Yeah. Sir, please be seated. Please be seated. We'll continue with also in very interesting proceedings now. Personally, to me, it is an immense pleasure to announce the names of the students who prepared the posters of very high standards. I have been constantly attending many national conferences, and I can say that the posters are of quite high standards, and the papers are also. So those who have got the prizes, they have got it, and those who have actually made efforts and responded with these high standard posters and papers, we will honor them with certificates and prize. To give away the certificates and the prize, I would request Dr. C.C. Rahul to do the honor. You be there. C.C. Rahul to do the honor. I will call names of the. Be there. Okay. We had 5 pre-papers, as you all know. One of the pre-papers we did not include, that we included in poster. So I will call upon all those who participated and did not get the prize, but prize is not everything. That I think the posters, papers require studies, DNB theses. So these are definitely somebody has done a thesis which is accepted by National Board, is of very high standard. Now I will call Dr. Anuja Kulkarni for her paper. Someone is taking photograph, please, with the dais.
Dr. Anuja was wanting a first prize.
No, it's a different issue altogether, but she is beyond, above the prizes. Yeah.
We have a second prize.
Next, Dr. Komal Kamble from the Department of Pediatrics. So these are the two papers who did not get the prize, but were of very high standard. Oh, he is there. We are honored to have PCMD East Coast Railway here to give the certificates to other students. As I said, there were 22 posters, out of which 4 posters were awarded, but rest posters are also very good, were good. The marks were very tying actually. So it was really difficult for me to judge from those 22 posters. Had I been a judge, there would have been a different type of prizes, but those who have won the prizes, they are fine, and then those who haven't won the prize also, they are very high standard. Now I call the posters, name of the students who presented the posters. Dr. Akshay Kavadkar from Department of Cardiology. His poster I liked a lot. Dr. Atiullah Khan from the Department of Pediatrics. He had 2 posters, and both the posters, there were immense work was done actually. Basically, immense observation in the Department of Pediatrics was done. Dr. Komal Kamble from the Department of Pediatrics. Dr. Pankaj Arangale. None of the students are going out. Please be here. From the Department of Pediatrics. Dr. Ganesh Kavle from the Department of Pediatrics. I would request Dr. Samantare sir to join on the dais to give her the prizes also. Dr. Pandurang from the Department of General Medicine. Dr. Pandurang. Dr. Vaibhav Patil from the Department of Surgery. A lot of efforts have been done, so it has to be appreciated with सुनाई देना चाहिए. बचते रहना चाहिए. Dr. Deena Surpam from the Department of Surgery. I want to hear the claps. They have made efforts. Dr. Nijesh SK from the Department of Surgery. Rest are clapping. I will budget. Leave away your phones. Palms only. Dr. Prashant Salve from the Department of Cardiology. Dr. Ayushi Jain from the Department of ENT. Dr. Nisma Loknath from the Department of ENT. Nisma is there. I request to collect on behalf of Nisma. Dr. Prachi Deshmukh from the Department of ENT. Dr. Aishwarya Patil from the Department of Obstetrics and Gynecology. Dr. Channabir Nalawat from the Department of Orthopedics. I think he is not there. Somebody collects it from later on. Somebody takes it later on.
Anyone can have. Anyone can have.
Dr. KB Ardeshana from the Department of ENT. No, चलो ना, कौन रह गया? I'll take a group photo. Good. And of course, Dr. Rinita Ajay.
Dr. Rinita, okay.
Her poster was of very high standard from the Department of Cardiology. The appreciation of students, because you are the brains, young brains, who are going to be consultants later on, has to be appreciated like anything. The clapping should be going on.
And the major contribution for the success of this conference goes you only. You started the
success
program.
of the conference goes to students only.
Only student. The excellent presentation, excellent cultural activity from all. Really, just heads up to you. Okay, thank you. Congratulations.
I ask all the students to come over here so that we'll take a group photo.
Okay.
मैं पहला बार देख रहा हूँ कि सारे को अवार्ड दिया जा रहा है, कोई भी कॉन्फ्रेंस में इतना रिस्पेक्ट स्टूडेंट को नहीं मिला है, तो आप लोग उसको बजाय रखना है, इस जगजीवन राम को सारा भारत में फेमस करना है.
Thank you.
Students to come over here to take a group photo.
All come here. Okay.
नाम नहीं लिखा ना, उसका इसके लिए एक ही सर्टिफिकेट है. Okay. You understand? Name of the topic नहीं लिखा इसमें. 2 certificates I'll give you. I have certificates. इसमें जैसे नाम लिखा रहता है.
When the residents are around us, now we are little bit relaxed. My student, that is Akshay, Prashant, Rinita, they don't ask when the speaker will come, how they will come, when they will leave the hospital. All were very well managed, and the quiz. I'm proud of having 3
Dr.
students and
Mangesh,
all the
Dr.
residents. Dr. Avinash,
Prashant sir.
You just come, Avinash. I know you want to prove you are a best photographer now. You want to dancer, poem writer, what I can. Okay.
बसणार नाही एवढे सगळे.
Hey, Mangesh, you present the best. Today your presentation is my award from my side.
काल जनरल मैनेजर साहब बोले कि ये डॉक्टर का जो कल्चरल प्रेजेंटेशन था, that is one of my best in life.
Thank you, sir. Thank you. Okay.
और मैडम भी जीएम हमारा सीएमडी मैडम बोले मैं जाके अवार्ड डिक्लेयर करूंगा आपको कॉन्फ्रेंस के लिए, बोले अभी मुझे पता नहीं कितना बचा हुआ है पैसा.
आइए सर.
आगे नहीं, बच्चों का पीछे रहना है. ये गुरु
कम से कम मुंडी आ रही है ना.
खाली मुंडी आएगा आपका और कुछ नहीं.
चलेगा.
अक्षय टेकिंग फोटो एंड टेलिंग सर गुप्ता सर की गाड़ी नहीं आया अभी आने वाला है.
देखो जो जगजीवन